Good morning. Welcome everyone to the fourth meeting of the Joint Interim Standing Committee on Health and Human Services for the 2023-2024 interim. Our committee secretary, please continue to call the roll.
Senator Nguyen.
Here.
Senator Titus. Assemblywoman Brown-May.
Here.
Assemblywoman Gorlow.
Here.
Assemblyman Gray. Assemblyman Hibbets.
Here.
Assemblyman Nguyen. Assemblyman Orentlicker.
Here.
Chair Donyate.
And I'm here. And please mark Senator Titus absent excused, and I believe Assemblyman Gray is running a few minutes behind, so when he joins, you can mark him as present. Great. Thank you so much. Good morning, everyone, and welcome to our fourth meeting of the Joint Interim Committee on Health and Human Services. Today is probably one of the most exciting meetings that we have. We are, if I'm aware correctly, it is Mental Health Awareness Month, and so today is probably one of the most important meetings that we have during the interim. It starts off our conversations on mental health, the infrastructure that we need to improve our state with. Today's focus is strictly on adult behavioral health. I know that there's interest, of course, in children's mental health. That meeting will, of course, happen in June. So today we'll start the conversations of what we're doing to improve our mental health system. And we do have a few elected officials, of course, that will be starting off our meeting today. And so it's very exciting to be in that conversation. I know that we're very eager, of course, to have conversations of where we're at and where we need to go, and so I'm truly excited and thankful for everyone that has been here today. Before we begin today's meeting, I do have several housekeeping announcements. First, I would like to remind everyone to please silence your electronic devices, especially cell phones and laptops. For members that are joining online, please mute your microphone when you are not speaking, but you can leave your camera on. Additionally, I do ask our presenters on Zoom to leave your cameras off and microphones muted until we call your agenda item. The Zoom video call has a chat feature. However, this feature is only to be used for technical assistance, and as a reminder that agenda items may be taken in a different order than listed between two or more agenda items may be combined. The committee's meeting materials can be found on the Nevada Legislature's website, and you can also sign up for electronic notifications related to any activity on the committee's website. And if you wish to testify in person, please go ahead and sign in at the door by the table so that we can communicate with you post-meeting. And if you do not wish to testify, we encourage you to also sign in so that we can contact you in case if anything comes forward. With that, let's go ahead and continue with public comment. Public comment will be limited to 2 minutes per speaker, and staff will go ahead and time each speaker during public comment. We ask that you do not repeat what any previous commenter has stated. In addition to testifying in person, members of the public may provide public comment in various other ways, including through written means. So we'll go ahead and start here in Las Vegas and then move on to Carson City and virtually. So is there anyone that would like to provide public comment at this time? Please come forward. Yep. You can, so go ahead and take a seat, and then when you're ready, you can press the microphone, and then you have 2 minutes after that. So just make sure you state your name in the beginning. Please proceed.
Giuseppe Mandel. I represent Desert Hope at American Addiction Centers Treatment Center. Not much of public comment, more of a thank you to all of you in the community, those I've not collaborated with, I look forward to collaborating with. Thank you to the Attorney General and his office, always being fully transparent and open to working with organizations like ours and the continued collaboration. I'm a person in long-term recovery. I've got a presidential award for service hours in the community with law enforcement. I have several sales awards. I was an all-state athlete at a very prestigious #1 football school in the nation out here in community, come from a good family, and that was all before I ended up homeless due to an opiate addiction. Prescribed and then ended up switching to heroin. I know these meetings get long. I know they get tiring. One thing about drug addiction or substance use disorder, alcoholism, it doesn't care what side of the aisle you vote on. It doesn't care who you identify as. It doesn't care who you sleep with. It doesn't care what race, gender, orientation you are. It is across all boards and affects all of us, from family as well as individuals. So just more of an inspiration that there are people like me, due to all the committees and boards and representatives that work out there, just to give you a little inspiration on those long, hard, argumentative meetings sometimes. I've been a part of them, that to keep going, because there are those that you do save lives with, and in return, there's thousands of us out there that go and help to bring our lived experience to you guys and hope for better change. But that's it.
Good morning. Thank you, Chair Donati and members of the committee. My name is Amanda Habish-Deloy, and I'm the director for the Nevada Institute for Children's Research and Policy at UNLV, and I'm also the immediate past chair for the Clark County Children's Mental Health Consortium. Now, as stated, I know you're not talking about children's mental health today, but as you do talk about adult mental health, we do just want to encourage to remind you that adults and children are separate, and to make sure that when you're making decisions about adults, that children aren't looped in when it's not appropriate to do so in those terms. So just to keep that in mind as you're having discussions, and we look forward to talking to you next month about children's mental health. Thank you for all that you do.
Just a point of personal privilege, Dr. Habusho-Deloyle was actually my former professor, so thank you for being here today.
Thank you, Senator Dunyatin, members of the committee. I'm here also on the same strain about children. We are Act for Kids Nevada. We're a neutral group that are advocating for a freestanding children's hospital. We have been collecting stories from families that live here in Nevada. I'd like to read a quote from one of them. Families traveling out of state must leave work, school, and family behind, having to make the decision to either travel and fear job loss or stay locally and not get the care my child needs is no way to live. This is a family that lives in Las Vegas. So many children are having trouble accessing health care right now in Nevada, and we look forward to a day that this does not need to happen, and our health care is not siloed in different hospitals and siloed in private medical practices. As a group, we're looking for change, and we look forward to the change. Here are a few things that we think will help this issue. Physician licensure and other healthcare workers licensure, and then working on measures to retain these healthcare workers. Just the general need for awareness for a children's hospital. I think people see a lot of signs and they don't understand that it is a fragmented system. And then also Medicaid reimbursement rate, seeing increases for these providers that are working so tirelessly to help our children here in Nevada. Thank you so much for your time, and thank you for your dedication to our kids.
And your name for the record too, please.
Chelsea Bishop.
Thank you.
Hello, my name is Kinsey Sigler. I am also here with Act for Kids Nevada. We are a grassroots movement, really trying to bring awareness to this need that we have for comprehensive pediatric care here in Nevada, specifically a freestanding children's hospital. I'm the mother to 4 children who are medically involved, 2 of which are deaf or hard of hearing. We have experienced the challenges of needing to travel out of state for care, but also accessing comprehensive care here in the state of Nevada. Our family has experienced the struggles of chasing symptoms instead of being a champion of solutions. When we go out of state, we're able to meet with a comprehensive team who can really come up with those solutions. And we see that need here. I'd like to share a brief story of another family through our organization who has experienced similar struggles. This is a Henderson family, and they say, without a full children's hospital, much of the communication between doctors and facilities is left to the parents to handle. When we visit a children's hospital out of state, clinics work together to coordinate our child's care. We are always impressed with how easy it is. As our state population grows, coordination of care is critical. And isn't that true? This coordination of care is so critical. And so we hope to help bring forth solutions, to help be a part of a team that can champion these solutions instead of chasing these symptoms with our children. And I echo the things that Chelsea has shared, finding solutions for retainment of physicians, Medicaid reimbursement, and of course, raising awareness for freestanding children's hospital. Thank you.
Thank you so much. Anyone else in Las Vegas? Carson City. Looks like there's a few folks. Please begin when you're ready.
Good morning, Chair Doniate and members of the Interim Health and Human Services Committee. I'm Madeline Larson, a Master's of Public Health student at the University of Nevada, Reno. I want to express from a student point of view that we, as students, need access to naloxone on campus to prevent accidental overdoses off campus. Students are using drugs and have always used drugs and will continue to do so, but now, more than ever, drugs used by college students like cocaine and Adderall are being laced with fentanyl. We must recognize that providing life-saving access to naloxone will not encourage drug use, but equip students to respond swiftly if an overdose were to occur. College is a time of experimentation, and no college student should be at the risk of death because of this. We cannot wait until a student overdoses to take action. Please consider sponsoring a bill that provides equitable access to naloxone to all Nevada system of higher education students to prevent a fatal overdose. Thank you so much for your time.
Anyone else in Carson City? EPS, is there anyone virtually?
If you would like to participate in public comment, please press *9 now to take your place in the queue.
Hi, am I connected?
Yes, you are. Please continue.
Thank you. Good morning, Chair Doniate and members of the committee. My name is Captioning, and I'm with Stand for Health Freedom Nevada. During the public comments portion of the last meeting of this committee, we heard from the director of the Nevada chapter of the American Academy of Pediatrics that they strongly encourage the removal of vaccine exemptions in our state. We presume, based on this statement, that they are working to accomplish this here in Nevada. Of course, this industry trade organization, which exists to protect vaccine profits, would like nothing better than to require each of us to consume their products without the ability to opt out. But does this benefit the people that you represent, the citizens that elected you all to represent them? This statement from the AAP comes at a time where public support of vaccine and medical mandates is at an all-time low, at a time where courts in other states are overturning laws that had previously removed vaccine exemptions for school attendance, at a time where many people have noticed that safe and effective is just a marketing slogan, and that the classic 1 in a million line used to discuss the vaccine injury rate is simply not true. Last week, the New York Times published an article titled "Thousands Believe COVID Vaccines Harmed Them." Also, just last week, AstraZeneca withdrew their COVID vaccine from the market after admitting in a courtroom that they knew early on that their vaccine caused blood clotting. Much more information is coming out every day about vaccines, and it indicates that the risks associated with taking them is much higher than we've previously been led to believe. The federal VAERS system shows 6,469 reports filed by Nevadans, population 3.2 million for the COVID vaccines alone, and that includes 53 deaths. Not exactly 1 in a million now, is it? We're here to encourage this committee to consider the will of the people of Nevada, to prioritize your constituents over corporate interests, to keep in mind, should you be approached by the vaccine lobby for legislation that would eliminate exemptions, that the majority of Nevadans do not support vaccine mandates. Thank you very much for your time.
If you recently just joined us and would like to speak in public comment, please press *9 now to take your place in the queue. Caller with the last three digits of 165, you are now unmuted. Please continue.
Yes, thank you. This is Michael Berry for the record from Senate District 15. I am also a certified peer support specialist and a community health worker up in Reno. I attend UNR as a full-time social work student, and I am also employed full-time working with Reno's unsheltered community. My interest and my stake in this community has to do with community outreach and harm reduction. I would just like to say that I am in support of having statewide access to the opioid overdose reversal medication known as Narcan. I would like to see one day it soon be offered from vending machines throughout our state, at health centers, clinics, and at the Sheriff's Department, just to name a few. I'm also interested in getting it into the Nevada system of higher education. I would like them to take the responsibility for the care of all their students and grant the agency to their residential advisors to allow them permission to provide this life-saving medication to someone in the throes of an opioid overdose. Currently, this is not the protocol. Currently, as it stands, and the residential advisor, if someone is overdosing on their floor, is to call 911 and wait. And we know that there is plenty of information and science that backs up that those minutes are crucial. I'm also interested in safe consumption sites in our great state of Nevada, and I hope to see bills related to this matter in the future soon. Thank you for your time and allowing me to comment publicly about what I am passionate about. Thank you.
Chair, you have no more callers at this time.
Thank you so much. We'll go ahead and close public comment at this time, and we'll move on to our first agenda item, which is agenda item 4, consideration of regulations proposed or adopted by certain licensing boards pursuant to NRS 439B. We'll go ahead and allow Mr. Eric Robbins begin, and then we can ask any questions following.
Hello, Eric Robbins from LCB Legal. We have 6 regulations to be considered by the committee today. 2 regulations from the Board of Medical Examiners, 2 regulations from the State Board of Osteopathic Medicine, and 2 regulations from the State Board of Pharmacy. And we should have representatives from each board attending either in person or virtually to answer any questions the committee may have.
Thank you so much. Committee members, are there any questions with any of the regulations or any of them that we would like to pull out? Dr. O.
Yeah, I have questions on the first 2 from the Board of Medicine, 03324 and 6823.
Great, thank you. Any other ones that we would like to pull out? The only one that I have questions on is R00124, which is from the State Board of Osteopathic Medicine. So let's begin with LCB file R033-24 from the Board of Medical Examiners. Vice Chair Warnlicker, did you have any questions specifically on that one?
Yes, thank you, Chair. Section 2, which talks about if you're going to practice in a specialty, have completed a residency in that specialty. And I know we have long had a requirement of 3 years of residency. But I'm wondering about the doctor who's completed 3 years of, say, a surgical residency, so they haven't completed a full residency. It sounds like they're not able to practice. And are there problems out there that we're seeing with doctors that led to this? And I know that more than 30 states license on the basis of 1 year of residency training, and obviously it's in statute for a while that we have 3 years, but it seems like we're tightening up at a time when we have a doctor shortage. So I'm curious about the background of this.
Sarah Bradley, Deputy Executive Director. Can you hear me?
Please proceed.
Oh, thank you. The background on this is really because we have people practicing in areas that they're not trained in and perhaps shouldn't be practicing in. So the intent here is to make sure that they document to the board. It's really not about the residency. It's about them designated to the board the specialty area that they intend to practice, and then basically making sure there's some proof or some backup support for that. So it would be a board certification by a specialty board of the American Board of Medical Specialties, or successful completion of a graduate program that does provide training in that specialty area. And then there's also just this option that they got approval from the board if the first two don't apply. But the intent is, again, just to make sure that they've documented to the board the area they intend to practice, that it is one they're trained in and skilled in. And this also would affect their physician assistants and make sure that those physician assistants only practice in that area that the doctor, the supervising physician, is basically competent and skilled in. So it's the concern we're seeing is, I think, public protection issues of people practicing outside the area of their training. And we're trying to document that better and enforce that better.
So let's say somebody's specialized in an area and just wants to deliver primary care, but they didn't do a residency in family medicine or internal medicine. Are they therefore not able to become a primary care provider? Is that the result of this?
I mean, they have to have, Sarah Bradley, Deputy Executive Director, for the record, they'd have to have some sort of training. Obviously, they go to medical school and that provides them a broad foundation basis. But I mean, they're going to have some residency because we require residency for licensure. And I suppose if they don't meet A or B, they would have to submit for the board to approve them to practice in family medicine or, but I've never seen someone practicing in family medicine or primary care that is not an internal medicine or family medicine resident, that they've completed that.
Okay, then the other thing, and obviously this is nothing you can change because it's in statute, but we have this 3-year residency requirement, and so the person who has completed 1 or 2 years of residency and I think has at least the training of an advanced practice registered nurse, but wouldn't be able to practice in the way an advanced practice registered nurse can practice. And obviously there's one difference. It's one person's completed their training, the other hasn't, and maybe that's a red flag that they didn't finish their residency. But have we set up a system where if you're a doctor, you can't practice even though your training is at least as rigorous as the advanced practice registered nurse? Is that where we are within the setting of a provider shortage?
Sarah Bradley, Deputy Executive Director, for the record. I don't think I'm qualified to speak to the qualifications of an advanced practice registered nurse, so I'm not quite sure how to answer that question. I would just say that, I mean, most licensees, the shortest residency time is for internal medicine and family practice medicine, as you're talking about, and I don't think we're seeing issues with them completing their residency. And as far as the rest of your question, I would have to defer that to another entity that can better answer.
Thank you.
Thank you. Yeah, I think I'm still trying to digest like the reason why we're going through this proposal. I mean, it would be helpful to understand, like, was there a scenario that prompted this regulation and it's as a repercussion, or I guess it's like the future of medicine is more on the collaborative care model. And so this to me feels like it's working retroactively. So was there a complaint that was filed, or you're seeing an influx of complaints of physicians that were not supposed to be treating the diseases that they're supposed to be treating, or to not, I guess, to the level of acuity that it needs? Or I guess it's minor. I'm just trying to better understand, like, what was the purpose behind this?
Sarah Bradley, Deputy Executive Director. We get a lot of complaints of people practicing outside their scope. These tend to be people practicing in cosmetic medicine. So this is not medicine treatment that's actually necessary. It's not medically necessary. So we have situations where individuals trained in obstetrics and gynecology are doing breast augmentations, sometimes in their office because they're not able to get hospital privileges and other privileges to do them, I guess I'd say, in the more proper way. Because again, with certain sedation, they have to have certain permitting. And so we also are seeing ENT doctors doing breast augmentations. Both of those things would be outside their scope, according to the board and according to their training. And then we're also seeing physician assistants practicing outside the scope of their supervising physician, potentially with their supervising physician's authorization. But again, this goes against And so we already have a regulation and statutes in place that talk about competence and keeping your practice within the competence of your training and education. This is our attempt to not only follow that, but say, please provide, that information to the board. We have most of this already when they apply for licensure. This would just make them designate a specialty. We would have it on record. And then for, again, supervising physicians, we would know, okay, their physician assistant should stay within their same realm. So it's really, again, emergency medicine doctors doing liposuction, not in a hospital, not medically necessary. Those are the things we're seeing. And that's why we're trying to, again, I guess, clarify and be more careful about that. So the concerns we have really are patient safety. We've had patients end up in hospitals almost dying from, again, having incompetent, untrained folks doing these procedures. And so we're trying to minimize that, but it's really the cosmetic area, non-medically necessary issues that we're concerned about. But those are the ones that seem to be hurting the public at the moment.
Yeah, thank you so much for that. This is like the part where I'm struggling to grasp, I guess, the unintended consequences that could result from such regulation, right? To me, this feels like this could impact probably the rules the most, because the physicians that are probably out there have to wear multiple hats, and they might not have the full residency training, but just simply because of the encounters that they have coming through the doors, they find themselves more in the training aspect where they work on the field versus a formal training of what a residency would be required. And I've seen scenarios where you might have a psychiatrist work with an internist or family medicine doc, and they work together in a collaborative agreement. But I guess the question is, if they're working together for years on, and they work simultaneously together in terms of the patient population they're seeing, does this requirement now arbitrarily limits the access to care model that we're seeing more and more progressively moving on? So I think it would, I don't know if that would mean revising it to where if there's a collaborative agreement that they have to submit that in exchange if they don't have the formal residency training program. But I see the rationale of what you're trying to do, but I just fear that there might be consequences of the actual delivery of care simply because now we're just requiring that you have to go get a formal training. So that's the only comment that I would have, that I would implore you guys to probably explore a little bit more. Let's go to Assemblywoman Gorlo.
Thank you, Chair. And, I do appreciate looking at patient safety. I think that's very, very important. But I'm curious how this regulation is similar or not so similar to other states, and would it actually take care of those bad actors that you mentioned, or is it those bad actors are still going to be bad actors and it doesn't really matter, unfortunately, what kind of regulations you have in place? So really my question is, how does this compare to other states?
Sarah Bradley, Deputy Executive Director. That's not something that I have information for at this time, so I'd have to do some research and bring it back to the committee. I do believe some states actually license by specialty. We tend to not. We license one thing, which is MD. However, again, we already have them designate on their application. We know where they went to residency. So we have all that. This is just going to ask them to tell us in the system, yes, here's my internal medicine documentation, and I'm going to practice in internal medicine or family medicine or whatever it might be. But we can definitely do some research on other states and see how they're handling this. I can tell you that all states that I'm aware of are struggling with the same issue. And I think the reasoning is cosmetic medicine, as we're probably all aware, is very lucrative. And so doing it as a side gig or doing it to add on, or even, gosh, I don't make enough doing family medicine, I'm going to just go ahead and do liposuction full time. Those things are all very, I think, attractive. However, I think our patients are suffering.
Thank you. Senator Nguyen.
Kind of a two-part question, because it seems like this is overly broad, and I have some of the same concerns that the chair had mentioned. And it seems like, is there any way to make the regulation more specific to capture, I guess, some of these cosmetic procedures or injectables? And then my second question is, do you have a way to quantify how many complaints we're getting in this area? Is it doctors acting out of the scope of their specialties, or is it other licensed medical professionals that are engaging in this, I guess, some of these more commercially lucrative cosmetic procedures and injectables?
So this is Sarah Bradley, Deputy Executive Director, for the record. We're having, I would say, an equal number of medical doctors and physician assistants engaging in this activity. We do license 3 other practitioner types, but they don't do procedures like this. And yeah, so it's not an issue with them. I can't speak to the other boards. I'm guessing that the nursing board and perhaps the osteopathic medicine board are also seeing some of the same things. As far as tailoring it, I mean, I guess the law already says that a physician must keep their work to the scope of their training and competence, period. It already says that. All we're doing here is saying you need to just tell us, I'm going to practice internal medicine, or I'm going to practice that. So they already have a statutory rule, I would say, to keep their practice limited to their scope. And they already have to tell us their residency. So this is really them just when they apply and or when they renew saying, yeah, I'm practicing family medicine or whatever it might be. We already have the documentation. We already, again, they're licensed. And so it's just making sure they put it essentially on paper. We do see occasionally other situations regarding treatment, but I'd say that's rare, meaning necessary treatment where people are outside their scope. I would say that's very rare. It's more people that are trained in classical medicine, again, the specialties, probably obstetrics and gynecology, emergency medicine, and otolaryngology, which I always say wrong. Those are the ones that are, I think, doing this the most. And it's not injectables that we're concerned about quite as much because the risks are a lot lower. And there's a long statutory list of folks that can do injectables. This is really surgeries. It's people doing surgeries without proper training. And we're seeing it a lot. And we are seeing patients, again, nearly die. We're not aware of a patient that has died yet from it, but multiple have ended up in the ER and had severe infections and other complications. And so again, our goal is just to make sure that it's documented and that they've told the board, yes, I'm going to practice in this area. And then once they designate that, then we have that in black and white, as well as we have their physician assistants. We have agreements. And so when we're talking about collaborative agreements, the only ones we have is with MDs and physician assistants, or MDs collaborating with an advanced practice registered nurse during their initial phase of training, their hours. Otherwise, MDs don't have them with each other or with others. Again, it's just making sure we have the documentation. So when we have a complaint, we have them designated, and then we can just say, yeah, that's outside the scope, and it makes it easier for us to take action against the bad actors. That's really what we're struggling with, is having the law clear enough and clarified enough that we can take action against the bad actors.
Thank you.
Thank you. I do want to move on because I know that we're on a fairly limited time today, but I think the notion of I think that your idea is correct, where physicians should be trained to do the services that they do, right? And if they're going out of, if it's performing a surgery that they've never been formally trained for, obviously that is problematic. But maybe I think what we see in at least in the primary care space is there is a lot of collaboration that exists, and so maybe we could say, like, if you're a physician and you don't have a formal training in this capacity because you didn't go through this residency requirement, but you're practicing in the space, like for the example that I made in an internist or family medicine doc working with a psychiatrist, and you can submit to the board a collaborative agreement of these two physicians are working together. They don't oversee one another, but they're still working together to serve the patient population that they have based on the needs of the community. I think that, to me, would probably solve this instance where, okay, well, since you're not formally trained here, you can't really practice here, but you're still accomplishing the ability to reach the community where the services are needed. But I think we'll go ahead and finalize questions. I know we'll probably circle back with you all before for this policy proposal. Let's go to LCB file R068-23 from the Board of Medical Examiners. Vice Chair Ornlicker, you had a question?
Yeah, thank you, Chair. I like the idea of in section 7, 2A, requiring doctors as part of informed consent to disclose their qualifications. That's great. I'm just curious, is there a definition anywhere of qualifications? Because that could mean where you went to med school, where you did your residency. It also could mean how often you've done this procedure, if it's a surgical procedure, what your results are, and is that just going to be sorted out by courts, or how are we going to know about that?
Sarah Bradley, Deputy Executive Director, for the record. We are actually working on still refining this language a little bit. So the way it was drafted by me, and my intent was, the person would say their board certification. So in other words, if a doctor is practicing in family medicine, the example would be they're probably board certified by the American Board of like internal medicine, or a related American Board of Medical Specialties board related to family care or internal medicine. So my intent would be they would say, hi, I'm Dr. X. This is my board training, and that's it. It's and depending on the kind of procedure, obviously, if you're going to have a surgery, there's probably going to be a written agreement or a written signed informed consent. But if it's kind of more routine care, it's just ensuring that the patient knows that this physician is trained in this, whatever the area is that they are trained in, and it helps that consumer, I think, make a more informed choice about who provides certain procedures to them. For a physician assistant, it would be similar. It would be, I'm Sarah, and I work with Dr. Jones, and he's a board certified dermatologist. That would be really what we're looking for the qualifications. And so initially, the way I had written this, I had referred to another statute that talked about board certifications. So we're working on kind of refining that. And there's probably going to be an addition that says something like qualifications includes the American board, the specialty board that the physician is certified by, because that was our intent there. And we wanted to make sure too, when physician assistants are providing care, that they verbally at least tell their patients who's their supervisor, because again, if something goes wrong, I know there's been situations where patients will see a physician assistant, and of course they do amazing care, 99.9% of the time, but there have been times where they'll have a question or a concern, and they don't always realize who's the supervising physician that maybe they could reach out to or should if they would like to.
Thank you.
Great, thank you so much. Let's go to LCB file R001-24 from the State Board of Osteopathic Medicine. This is more of a comment, not really a question, but I feel like it seems like I repeat the same issues, and like I see the problems go from one agency to the other, and it's the same thing over and over again. I've alluded to just my frustration when we require applicants to have a proficiency in English. This is more of a concern of, I think that if we're in a position of accepting physicians or medical professionals from other countries, and when we put things like this in statute, it limits our ability to serve the population, and then we're already in a critical need. So I know that a lot of times we just copy and paste regulations from other states or from other statutes, but I've had LCB poll like how many professions we have in the state that require English proficiency, and it's about, I don't know, like 5 or 6. It's not that many. And so I would just implore you that you take in consideration back and remove that portion of the regulation, and instead just allow the flexibility of the board to decide whether or not that person has a proficiency to practice. I think that to me is more preferential than just saying, you don't speak English, you can't come here. But that's my only recommendation. Okay. I think we'll go ahead and close this agenda item, and we'll move on to our next one. So I thank all the boards and commissions for joining us. I know we had a lot of questions, and I implore my committee members to ask offline if they do before some of these become finalized. Let's go on to agenda item number 5, a discussion of recommendations from the Substance Use Response Working Group established by Assembly Bill 374. With us, we have a very special guest, our Attorney General, A.G. Ford. So please feel free to come forward, and we'll begin when you're ready.
May I proceed? Good morning, Chair Donate, Vice Chair Ornlicker, members of the committee. It is great to see you all. My name is Aaron Ford, and I am your Attorney General. Delighted to be here today to talk about recommendations coming out of the Substance Use Response Working Group Committee, affectionately known as the SURGE Committee. I will say at the outset, I know that we have a lot of slides here, but fret not, we are not going through all of the slides. It is intended as a reference for public comment, but for public engagement, but also for you to review at your leisure. We will talk about specifically the recommendations as they come out. And not talking about all the slides actually bodes well. I recently had a dental procedure that I'm still feeling the effects of today and may not be able to talk as much as I normally would, so you are being blessed in that regard. So let me begin. I'd again like to thank the joint, pardon me, before I do that, let me introduce my colleague, Dr. Terry Kearns, who is a partner of mine in the office here at the Office of Attorney General. Dr. Kearns is my specialist, so to speak, in the opioids arena, but also in substance use and abuse disorder arenas. She has a master's degree in nursing, but also a PhD in emergency management, and has been a very instrumental part of this office well before I got here and will continue. I also have in the audience, either up north or down south here, some members of the SURGE Committee, one of which obviously is our chairman, Mr. Donate. Thank you so much for your service on that committee. We also have in Carson, Steve Shale, and Eric Schoen, and here in Las Vegas we have Dr. Dixon. And so to the extent there are questions that may touch on their expertise, I encourage them to likewise present to the committee. With that, let me move to slide number 1. Again, I'd like to thank the Joint Interim Standing Committee on Health and Human Services and chair members, as well as members of the public, for the opportunity to present the recommendations from the SURGE Committee 2023 Annual Report. In slide 2, we note that the Nevada Revised Statutes has established the SURGE Committee to highlight a few of the mandates of the SURGE. One is to comprehensively review various aspects of substance misuse and substance use disorder, and programs and activities to combat substance misuse and substance use disorders in the state. Also to annually get a report from DHHS on the use of state and local money to address substance misuse and substance use disorders, as well as to study, evaluate, and make recommendations concerning the use of that money. Slide 3 talks about the membership of the SURGE Committee as laid out in the NRS, and these are the 18 members that make up the SURGE Committee. As you can see, the membership crosses many disciplines involved in substance use prevention, treatment, and harm reduction, and it includes legislators and it also includes those who have been affected by substance use. Giuseppe Mandel, who you heard from earlier, is not on the committee, but he attends almost all of our committees as an individual who can provide firsthand experience and public comment on these types of issues as well. We thank him for his appearances. In slides 4 through 8, I will not go through all of those, but I've outlined the NRS that the SURGE was what we are to do and what's outlined in slides 4 through 8, A through Q. Again, I won't read those to you, but put them in the slides for you to see what the SURGE was tasked to do. In slide 9, the NRS also included special populations that the SURGE was to consider when making its recommendations. That's there for your review as well. In slide 10, am I going too fast, Terry? We're okay? Okay. In slide 10, the way that the SURGE decided to approach our work was outlined in NRS 459, was to establish 3 subcommittees and to assign the tasks previously discussed in A through Q to the appropriate subcommittee. SURGE members were asked to work with one of the subcommittees they had expertise or interest in. The 3 subcommittees are prevention, who also addressed harm reduction, treatment and recovery, and response. There were also some tasks that were cross-cutting. There could have been many more subcommittees, but due to personnel and due to funding, we had to limit our subcommittee number to 3. The prevention subcommittee addressed items A, G, and J. Harm reduction, which the prevention subcommittee took the lead on and addressed J. In slide 11, the Treatment and Recovery Committee addressed items C, E, and F. And then you will notice in slide 12 that the Response Subcommittee had the majority of the items comprised of D, L, K, M, N, O, and P. The cross-cutting items were B, H, Q, and L. The subcommittees met more often than Surge. The Surge Committee met quarterly. The subcommittees developed their recommendations by either having members make suggestions, or there were subject matter experts, or SMEs, that presented information to the subcommittees, and recommendations also came from these SMEs. The subcommittees worked on the recommendations by addressing justification and background, which included research and evidence-based practices. What was the impact, capacity, and feasibility of implementation? Urgency, and how the recommendation advances racial and health equity, and what recommendation action step was. After the subcommittee developed their recommendations, they were presented to the larger Surge Committee, and the Surge Committee either accepted the recommendations as they were, suggested that they go back to the subcommittee for future work, or in some cases, there were recommendations submitted by different subcommittees that were similar in nature, so one subcommittee was tasked with combining similar recommendations. After the subcommittees completed their recommendation, the Surge ranked and voted on these recommendations, which you will see in the Surge 2023 annual report. In slide 14, the process that I described resulted in 18 ranked recommendations and 2 unranked recommendations. In slide 15, of the recommendations, there were 12 recommendations to expend opioid litigation settlement funds. There were 5 recommendations. Pardon me, by the way, if you have a question, you can stop me in the middle of this, obviously, Mr. Chair. There were 5 recommendations with an action step for a proposed bill draft request. There were 4 with a policy action step. And finally, there were 2 recommendations to spend other than opioid litigation settlement funds. As you can see, these numbers don't add up to 18 recommendations, because some of the recommendations have more than one action step, such as a proposal of a policy change in spending funding. The Surge has no funding, nor does the Surge have BDRs. So the recommendation for funding has to go to the appropriate place, such as DHHS or for the Fund for a Resilient Nevada. For BDRs, someone has to sponsor those. My office, the Office of Attorney General, will sponsor some as well, but we also will be looking to legislators to help sponsor some of the legislation that has been proposed. For policy changes, those have to go to the agency with the actual policy. In slides 16 to 20, I will talk about the fact that there are 11 ranked and 1 unranked recommendation to spend opioid litigation funding. Let me segue real quickly just to let the committee know and the public know that the Surge Committee makes no decisions regarding the expenditure of opioid settlement funds. None whatsoever. Nor does my office, the Office of Attorney General, make any decisions regarding how this money should be spent. It is by statute deferred to and referred to HHS and the and committees therein. So we make recommendations. The first recommendation was to DHHS, DPBH, and I know I'm using a lot of acronyms, and hopefully you would know what these are, and the Bureau of Behavioral Health, Wellness, and Prevention, to double the amount of investment in primary prevention programming. That is, to increase from the current $12 million that's allocated to $24 million for this biennium for ages 0 through 24, and to review the funding allocations annually. This funding should not be at the expense of existing programming. We are not suggesting supplanting other programs. We are asking for additional monies to be expended for this purpose. Recommendation number 2 was to expand access to medicated assisted treatment, or MAT, and recovery support for SUD. Remind me what SUD is?
Substance use disorder.
Substance use disorder. Limit barriers to individuals seeking treatment regardless of the ability to pay, and to encourage the use of hub and spoke systems, as well as recovery support, including use and promotion of telehealth, considering the modifications that have been made under the emergency policies, and pursuing innovative programs such as establishing bridge MAT programs in emergency departments. I know, I believe it was Assemblyman Ornlicker worked on MAT-based issues last session, as did my office as well. So this is in line with that type of approach. Recommendation number 6 is to implement a specialized child welfare service delivery model, and will follow up and referral and linkage to care that improves outcomes for children and families affected by parental substance use and child maltreatment and pregnant or birthing persons with substance use disorder. Recommendation number 7.
AG Ford, just
Yes.
Is it, not to cut you off, but
That's okay.
would it be helpful instead if we could just maybe have the committee members like review the recommendations in the report? That way we can have more of a conversation. Is that fine? Or
Yes, absolutely.
okay. Is there anything that you wanted to mention before we start our questions, or I don't know if at the end of the PowerPoint presentation if there was anything else you wanted to.
Pardon me one second. Okay. If you would indulge me, recommendation number 8 is one of the things that we did want to highlight. And it's on slides 27 and 28. Allow me to get to that. Okay, and that's the last recommendation, which had an action step of a bill draft request. So recommendation number 8 is to support harm reduction through implementing changes to recruit, retain, and compensate health and behavioral health care workers, and enhance compensation in alignment with the Commission on Behavioral Health Board's letter to the governor dated June 22nd of 2022. Additionally, to continue to sustain and expand investment in community health care workers, community health workers, peer recovery specialists, and certified prevention specialists. Continue. Recommendation number 9, which require an amendment to an existing legislation, is to evaluate current availability and readiness to provide comprehensive behavioral health services to include but not limited to screening, assessment, treatment, recovery support, and transitions for reentry in local and state carceral facilities. To also recommend the allocation of funding to support the development of a Medicaid reentry Section 1115 waiver to increase health care for people leaving the carceral facilities, and to support readiness of carceral facilities to implement 1115 waivers. But also to recommend legislation to require the state to apply for and implement 1115 waivers for purposes as well. There's also a bill draft request to change the Nevada paraphernalia definition as it relates to smoking supplies, as well as a recommendation that a compliance study be completed for NRS 259.050, and a recommendation regarding additional harm reduction, that's number 18. The final one that I'll mention is that there has been a request that we add a few seats to the Search Committee, which would likewise require a bill draft request to be utilized for that purpose. And so with that, Mr. Donate, I will tender the mic back to you.
Thank you so much, AG Ford, and of course to Dr. Kearns. So I think probably the most important thing of this moment is more of a dialogue back and forth between, obviously, like, the mental health system in our state is very complex, and there's a lot of different positions and opinions of what you tackle first and what needs to be prioritized versus maybe not now. And I think it's, for me personally, even developing this agenda item was, not just this agenda item, but this entire agenda for today was probably very difficult because there's just a lot of things to do, right? And I think you have that included as part of your recommendations, where some of the community folks have already helped illustrate like what needs to be done to take our mental health system to the next step. But maybe for today's purpose, just to start the questions from our committee members, let's start with like a basic question. And I think my preference is for all the presenters today to answer this base question, and we'll start with our AG first. If you had one chance to fix the mental health system, like what would you focus first? I think that's probably the most important thing, regardless of the funds or the expediency of what needs to get done. Like between Dr. Kearns and of course to our AG, what needs to be done like now, I guess would probably be a good question. And we'll allow that, of course. I mean, when we have our elected officials, obviously in a different agenda item, and we'll ask them as well. But just from a personal stance, I think it would be helpful. And my understanding is your office also deals with, we've had the conversations of the trafficking of fentanyl and so forth. So I just want to have, perhaps just from a human perspective, what you think needs to be done to fix the system.
Thank you, Mr. Chair. Aaron Ford for the record. I've been invited additional committee members here to chime in as well, and you've asked for a personal opinion in that regard. I will offer that to you based on overlapping work that my office does outside of the search committee, but also in our mental health and also criminal justice systems. And what we have learned, what has been reiterated to me from what I learned when I was sitting in your seats, was a lack of resources, but not just capital resources, but also human resources and facilities and professionals. We don't have enough beds, for example, to deal with the mental health issues that we see coming either through the criminal justice system when it comes to those who are not entering the criminal justice system, but also who need this assistance. It's a pie in the sky wish. It's nothing you can really do about it at this juncture, right? I mean, it's a long-term strategy that the state has to undertake relative to constructing facilities, relative to recruiting and retaining professionals who can work in the area of mental health and ensuring that we're able to provide the wraparound services to those individuals who need these types of services in the mental health arena. We're seeing big problems, and I'm going to tender the mic to those to my colleagues here, but we're seeing big problems even outside of the search committee in those particular arenas, not having enough beds to be able to house those who need the assistance that mental health service providers are providing.
Terry Kearns, for the record, I would agree with what Attorney General Ford said. It's the ability to have access to care, not only in facilities, but also in that personal capital. Oftentimes, when someone's ready to get into treatment, there's not a bed available for them, or our emergency rooms are used as holding areas until a bed does become available for those needing it. And then also in talking to colleagues for trying to get medication assistance in jails and prisons, it's not just a funding issue, but it's, again, having the personnel that are available to do those types of programs.
It is worth noting, Aaron Ford for the record, beyond the scope of your committee to be sure, but it is worth noting that our state is being sanctioned by courts almost weekly because defendants who are also mental health, in need of mental health issues, have no bed to go to. And even if a court requires us to send them to a mental health institution, we cannot and have not been able to do that. And the waiting list is humongous. And we are literally being sanctioned by courts, north and south, on this particular issue. And that's happening, again, on a weekly basis. And that just further demonstrates the need that we have for that particular resource that I've laid out.
Hi, this is Dr. Leslie Dixon. For the record, I'm an addiction psychiatrist. I've been practicing addiction psychiatry for about 30 years, both in New York and now in Nevada. And I have to echo the problem with resources are very limited. One of the things Dr. Attorney General was referring to is the beds. You know, there's a lot of folks that end up into the criminal justice system that have competency issues, and so therefore they have to be referred to a state facility for evaluation of competency and restoration of competency. And there's been an effort. There's more beds now than there were, say, 5 years ago with Ross and Neil adding the Stein Hospital. But what's happening now is there's such a demand for that they have taken over, the forensic units have taken over much of the civil beds in Ross and Neil. So we have lost a lot of our civil beds for those who are committed, say, for mental health treatment. We don't have as many beds as we used to. And this is the kind of thing that just keeps happening. I don't feel there's any overall planning going on. There's no, and that. Now, as far as resources in terms of people, workforce, we have done, I think we've done a really good job of getting more psychiatrists. The residencies, we have now 4 residencies, psych residencies in the state. One of them did increase their number by 2, but our residents are not staying. And one of the reasons they're not staying is they can get much better paying jobs in other states. There are very few jobs. Psychiatrists and probably a lot of other medical doctors are no longer wanting to go out, open an office, hang a shingle, and take out a loan for $300,000 or $400,000 to open their office when they already owe $300,000 or $400,000 in medical school debt. So what we're looking more for is jobs, and those places don't exist to any great extent. We're not getting the interest. When it comes to substance abuse, there's not a lot of interest in treating substance abuse, and it's very hard. We have an addiction medicine fellowship started here a couple years ago. We are now going into our 4th year. But across the nation, the addiction medicine and the addiction psychiatry fellowships only filled 60% of the positions that are available. It's not a big interest. Why is it not a big interest? I can't answer all that question. I love doing it myself, but there's no money in it. And, Medicaid rates are extremely low. And one of my clinic supervisors was telling me about the Medicaid problem. And we do both methadone and buprenorphine. And the methadone rate per day is the same as it was 40 years ago. Something has to be done about reimbursement if we're going to have people stay here and work and take care of these folks. Is that enough?
That's good.
No, thank you for that. All right, committee members, any questions or anything? Vice Chair Ornlicker, and then we'll go to Senator Nguyen.
Yeah, thank you very much for the work of Surge, and it's really great to see the recommendations for harm reduction and some of the other needs. One question I have is whether the recommendations will address a problem I've seen in Clark County. We have clearly a big problem with opioid use and substance use dependence, and we have a program, Track B, that has a harm reduction facility, but they only have one brick and mortar facility for the whole county, and I've been working with them to try to set up a second one in an area on the east side where there's a lot of need, but just finding a location, it's not for lack of money. They have the resources to fund it. Just finding a place to set it up. And, there are restrictions. You can't be too close to a church or a school. And it turns out there just aren't a lot of places. Does the recommendations address that problem? Trying to find, just so you can set up the facility and get it going and have it near where the users, it's convenient for them.
Terry Kearns for the record. Thank you for that question. The Surge does have recommendations on harm reduction and specifically does call out some of Track B's programs. The recommendation looks more at their mail program that they have and throughout the state, not just here in Clark County. And it's my understanding that oftentimes on grants and funding, there are limitations on how the funding can be used, such as for buildings and those sorts of things. But I believe with the Fund for Resilient Nevada, there is not that restriction on how the funding can be used. So, but I think you're going to be hearing more from Don Yohe today on how those funds will be used.
As an aside, Aaron Ford for the record, I'd ask that if Mr. Shell and Mr. Schoen wouldn't mind in Carson City going to the table, if you want to offer opinion, I'd appreciate that.
I'm not, this is Leslie Dixon, psychiatrist for the record. What exactly is it that you're asking that is not available?
Well, just a parcel of land that will accept this kind of a facility.
And the facility does what?
Provides harm reduction services, needle exchange, wound care, and, advice, and connection to therapy, counseling, just, a range of services for users to help them address their dependence and reduce the harm from their dependence. And, and as a county as big as Clark County, we ought to have more than one brick and mortar facility. And as I say, it's not for lack of funding. The money's there. It's just, where can you put this facility that, somebody, the landlord will allow it, or, it doesn't violate any zoning ordinances. And this has turned out to be a serious problem, bigger problem than I expected.
Well, I'm not going to answer all that because I don't know the answer to that, but I do know that the clinics that I work in, which do medication-assisted treatment, we do have vending machines for those items that you would get in a special place. And I know we're going to hear later from the crisis centers that they're trying to establish, and all the problems that go into that, establishing these kind of freestanding places. It's very expensive, and there's a lot of liability, and so I'm not sure. I think there's problems in getting it going, but I don't really know what has been attempted.
Additionally, Terry Kearns, for the record, I would add that there are vending machines throughout Clark County and also throughout the state, as well as the mail program provided by Track B. But this has been a problem even with the vending machines. The folks who put those out went and had community meetings and all that, and then they went to put one in, and not in our neighborhood. So it's going to be a continued effort of education, and also a safety issue too. How many people are getting stuck by needles because they're not getting a return, but end up out on the streets and those sort of things. We do have a representative from Track B, or a former representative from Track B, Chelsea Cheatham, on our board, who does address many of these things, as well as harm reductionist.
And final response on this, Aaron, for the record, it sounded like a zoning question to me, frankly, and fortunately my colleague, former Senate colleague and roommate Justin Jones, current commissioner, is here as well. He said he can speak to the zoning questions and issues. That's my wife. Sorry, y'all. I'm going to tell her y'all made me ignore her. But the zoning issues he can address, and I know that Clark County, utilizing opioid funds out of Winston Thunder, is also looking at establishing a new facility for opioid use, and probably beyond that, disorders as well.
Thank you so much. Let's go to Senator Nguyen.
I have a couple of questions. I know that on the Surge Committee, obviously it's 18 people, so I know that's a lot of individuals. I have some questions, just because I know I brought legislation both in 2019 and then again in 21 and then again in 23 around the Medicaid reentry section 115 waiver. And it's my understanding in talking with Medicaid that they're actually in the process of doing that. So it doesn't seem like this needs an action step of a bill draft request, because it already is in law. So I just wondering about that. So, and I'm sure Medicaid can come up and speak to that as well. The other thing that I have a question of is, we see all these recommendations, and I'm thankful for the work that the group has done. Are any of these recommendations a part of a more overall, strategic plan on how we are addressing this? It seems like some of them are more substantial, some of them are more Band-Aid, a Band-Aid where a tourniquet is needed. But more appropriately, is there any action going to be taken by Surge to come up with a more, comprehensive strategic plan, so we know where these recommendations fall within this plan? I would hate to take one of these things that's just a piece of a pyramid with no foundation. So I guess that's my question. I know that's kind of rambling, so thank you. And you should have taken that call, Attorney General.
Why would you say that on the record? Aaron Ford for the record. Let me address the question about a strategic plan from the chair's perspective, but also my colleagues can speak to it. We make recommendations to the committee that is required to have the strategic plan. And there is a strategic plan, a statewide needs assessment that has been created by HHS. The Advisory Committee for Resilient Nevada has been working on that as well. So there is a strategic plan that exists in several counties, probably Clark County included, I shouldn't speak for them, is also either working on or has already implemented a strategic plan themselves. Now, this is specific to opioid and opioid-based issues that the settlement funds are able to fund. I can't speak to whether there's a broader plan for substance use disorder beyond that, whether it's methamphetamine or whatever the case may be. For opioids, Senator Julia Ratty established the structure for the ways in which this committee would operate, including the membership. We make recommendations only. We don't make decisions. And those recommendations go to not only the legislature, but they go to the Advisory Committee for Resilient Nevada and HHS for implementation to the extent they want to utilize that for purposes of their strategic plan and the needs assessment. So that's the short answer to your question in that regard. But I believe there may be anything else you want to add, Dr. Kearns?
Terry Kearns for the record. I would add that, yes, there is this statewide plan that was required to be done as part of the opioid litigation settlements and the needs assessment and the state plan. But in addition to that, it was mentioned at the beginning that we get a reporting from DHHS. They did do fund mapping to look at where the opioid funding is, whether that's through grants, endowments, those sorts of things, so that we already know what is being funded versus trying to put more money on top of something that's already, and trying to make it more equitable across the different areas that we talked about within the committees. And I did talk to Sarah Dearborn about that 1115 waiver, and I think it's possibly an amendment to look at the reimbursement rates.
Thank you so much. Let's go to Assemblywoman Brownway.
Thank you, Chair. Thanks for the presentation. I really appreciate that. Over the course of this last year, I've had the opportunity to serve as the Nevada Fellow for an opioid crisis with regard to the National Conference of State Legislators, right? So really been investing in sort of this recovery area and how do we get the correct items to the people in need. With regard to funding and duplicative, right, efforts, I'm curious to know, your recommendation number 1 is about DHHS. And funding, increasing the current funding $12 million to $24 million. I'm curious to know if you can talk about, have you had conversations with DHHS, right? Have we engaged Division of Public and Behavioral Health? How are you being received in those conversations? Does it look like a budget presentation is being considered as they develop the next biennial budget?
Terry Kearns for the record. We did have a presentation from DHHS on the funding that was done, and I believe that was to the prevention subcommittee, and again, to know what's already being funded. Admittedly, the committee may have asked for more than what they thought they could get, but just wanted to at least put a starting place on an amount to look at. And these presentations have also, or these recommendations have also been provided to DHHS. And I would ask Eric Schoen, if you are in Carson City, if you'd have anything to add. He was on the prevention subcommittee.
Chairman Dunyate, is it all right if I speak?
Please proceed.
Oh, thank you. So Eric Schoen, for the record, member of the Surge Subcommittee. Specific to the recommendation to double the amount of funding for prevention, I've been providing services in rural Nevada for 30 years, currently as a CEO of Community Chest, where I've been working for 28 years. Provide blended integrated health and human services, including mental health and substance use disorders. And when I'm asked what we need, it's basically 2 things. And it really comes down to funding. Funding for personnel or creative ways for getting more personnel out there. So one of the other highlighted recommendations is to really support the development of community health workers, peers, and prevention specialists so that they can help us with the work that needs to be done. But secondarily, funding for facilities and just sort of program overhead. We have decades of underinvestment in all of these needed critical areas, and the recommendation was made really to prompt the conversation that we're having now. What is an appropriate level of funding? It's not enough that what we currently have is not near enough to meet the needs. We've acknowledged that several different times from different speakers already. So what is an appropriate level? And we're not saying that funding can't also be increased for treatment and for harm reduction, but we on the prevention subcommittee felt strongly that we needed to put a statement out there that this needs to be increased. So after looking at all of the different funding that was coming through based on the presentation from DHHS, we thought that was an appropriate level to recommend. Is it compelling? I think so, which is what we wanted that to be. We wanted that to be something that would prompt conversation. What would be a good level to start funding these services at so we can provide the level of support that we want to for all Nevadans so they can not only survive but thrive.
Aaron Ford, for the record, I want to highlight that I sent the subcommittee back when they came with $24 million. And I said, y'all need to be certain that you have a delineation as to how this money would be spent, why you came up with that particular number. And, you know, because I knew that there would be questions specific as to that particular number. And they came back and they've been able to identify it. I literally sent them back and said, I'm not going to submit this until you do extra work on it.
Yeah, I think the challenge that probably exists is, as just context, myself even, I've gone through this of kind of like my own version of training of like legislative history before even this agenda came forward, because I feel like we're having conversations that have persistently happened over the years, and we're kind of in the same cycle where I think the answer obviously is funding, but the question is, okay, if these funds do come for, say, we're doubling the amount of efforts that can go into primary care or prevention so that we're upstream, not downstream, right? We're focusing on prevention versus treatment. And it's obviously difficult because there's this nuance of, well, we did that, but that didn't work. Or we did this, but it's not working exactly the right step. And so, like, what's the vision, right? I think there's a conversation of accountability of, okay, so you receive these funds, who's accountable for delivering on making sure that, like, at the end of the day, the person receives the care that they need, right? If we don't have enough beds, then, and once we fix that situation, which I think we all have to have a conversation of where does that funding come from sustainably so that we don't find ourselves in this Band-Aid approach, I guess, to the end of who has the appropriate accountability to make sure it gets done. I think that's probably, to me, it seems like that's more of a theme of what the situation that we're currently in. But I would love, I think the search committee is probably, if we provide you more finite resources, I think you can get to the point where it can be kind of that community-driven approach where we have physicians, we have community members that have been impacted by this crisis. And then if you have the right support, you can provide some direction of what needs to get done first. And then there's a level of accountability of, okay, this got done, let's make sure it gets done correctly, right? I think that's probably would be the next step. But I don't think there's any other questions for this item, but I sincerely thank all of you for being here, and I know that there's obviously more work to be done, and hopefully we can work together as we review some of the BDR requests ahead of August. So thank you so much.
Thank you so much, Chair Donate. Thank you, committee.
Of course.
Bye-bye.
We'll go ahead and move on to our next agenda item, which is agenda item number 6, a discussion of behavioral health efforts by certain local governments in Nevada. I did mention to our guest presenters that today is also Bring Your Elected Official to Work Day. We do have a lot of elected officials, of course, that are representing different jurisdictions. It's important to hear from our colleagues that serve in different parts of the state as to what's going on the scenes and what they're focusing on primarily. And so we do have a few folks. We have down here in Southern Nevada, we have Commissioner Justin Jones. Councilman Knudsen mentioned to me that he'll be a couple minutes late, so hopefully he'll come in time by the time we do this. And then in Northern Nevada, we do have Commissioner Mariluz Garcia and then Mayor Shivi. So it's a lot of different perspectives that we'll have the conversations for, but let's start with Northern Nevada if either the Commissioner or Mayor Shivi can begin their conversations. And I don't see, are they? There you go. Let's start with Commissioner Jones since he's at the dais. You can begin.
Very good. Chair Donate, Vice Chair Orentlecker, and members of this committee, Justin Jones for the record. Thank you for the opportunity to appear before you this morning alongside my counterparts from the City of Las Vegas, City of Reno, and Washoe County for a discussion of the efforts that we're making at the local level to address behavioral health concerns in our respective communities. And I just want to say on a personal level, as someone who has battled depression for years, I appreciate your time and attention to this issue because it is something that so many people suffer from in our communities. 2 years ago, I joined Councilman Knudsen in a community-wide stakeholder discussion on how to better serve the needs of individuals facing mental health crises in our community. And over the past few years, Metro and other law enforcement agencies in Southern Nevada have made significant investments in crisis intervention training for officers. However, the system in large part has operated as follows. 1, person in crisis or family member calls 911 dispatch. 2, law enforcement officers are deployed. 3, law enforcement officers handcuff person in crisis and transport them to one of 2 locations, the Clark County Detention Center or UMC emergency room. Dr. Stephanie Woodard, who was at the Department of Health and Human Services for many years and is now at the Gwynn Center, educated on a different evidence-based model for assisting those in crisis. Under this model, Step 1 is the person in crisis or family member calls the 988 mental health crisis line, where they can talk to a mental health professional. 2, if the situation is not de-escalated by phone, mobile crisis response teams consisting of mental health professionals and peer support specialists are deployed to the scene. If the mobile crisis team is unable to de-escalate, the person in crisis is then transported to a crisis stabilization facility, which is again staffed by mental health professionals and peer support specialists. Dr. Woodard arranged for a hands-on tour and discussion with crisis intervention professionals in Phoenix, Arizona, which has successfully implemented the model for many years. Last year, several of us were able to meet with leaders in other jurisdictions that had successfully implemented the crisis intervention model, including San Diego, Denver, and Miami-Dade County. The state issued an RFP for crisis stabilization centers in Southern Nevada. Although there was interest from both med-surg hospitals and psychiatric facilities, none moved forward because they could not make it pencil financially. Having seen the model and caught the vision for how to better serve the needs of those in crisis, the Clark County Commission and our senior management team decided to step in, work with the state, the cities, and other local partners to stand up a pilot program for crisis stabilization. As you will hear more about in detail this afternoon, Clark County recently purchased a turnkey behavioral health facility to serve as Southern Nevada's first of its kind crisis stabilization center. It will be operated under UMC's hospital licensure, and we are optimistic that it will open by the end of this year. Thank you to the Nevada Department of Health and Human Services and the Legislative Interim Finance Committee for agreeing to fund the purchase of this building with ARPA dollars. Working through the Criminal Justice Coordinating Council, Clark County has also collaborated with Metro and the Justice Court to stand up a mental health court. There are many opportunities in our community for standing up these types of facilities. And in many of the jurisdictions that have been successful, they have access to funds that we simply do not. In San Diego County, they benefit from a millionaire tax. In Miami-Dade County, they collect a 1% sales tax on food and beverage for homeless programs that support mental health services. And in Denver, they have a 1/4-cent sales tax that funds their programs. Clark County appreciates all that the legislature and the state are doing to meet the needs of those with behavioral health concerns, and we look forward to working with you during this interim to come up with ideas for long-term, stable funding options to meet the pressing needs of our community. To address the question that you posed, Chair Gignate, that is the #1 issue that we face. The state has provided fantastic funds for one-time funds for many programs, such as the funding for the purchase of the Crisis Stabilization Center. However, in order to make that facility, or frankly any facility, viable, there has to be a dedicated funding stream for years to come, whether it be a local government entity or it be a private or nonprofit healthcare agency. Without the ability to count on those funds for years to come, it is not viable to move forward with the capital investment costs that go into funding these programs. Thank you very much for the opportunity. I'm happy to answer your questions and engage in any dialogue you'd like.
Thank you so much, Commissioner. Let's go up north to Mayor Shivi and Commissioner Mariluz Garcia if you guys want to begin.
All right. Good morning. Thank you so much for having us. First of all, I really, really appreciate everyone's time and attention to this. I think it's truly the #1 crisis in America. Just to reiterate for the record, Mayor Hillary Shivi, City of Reno. You know, as a mayor, cities are at ground zero. Truly, we are at ground zero of this crisis. I cannot begin to tell you how challenging it is and how disheartening it is to watch literally people, loved ones having to be arrested to get them access to mental health care. It's unbelievable that that's what it comes down to in this country. It's the only health care crisis that we send police officers to. Does that make any sense? That is outrageous. And if we do send a clinician, you really better hope it's between 9 to 5, because that's the only time we have most teams and clinical workers to address this situation. We've got to, and matter of fact, I'm very, very passionate about this, but you know, listening to a lot of the testimony, it was so evident we've got to stop using our jails as mental health hospitals. It's got to stop. That's how we treat mental health and addiction in this country. We also use the ERs, and however, ERs are great if you have broken bones, but what about broken brains? So as a mayor who's been talking about this all year long as my presidency for the United States Conference of Mayors, along with Steve Shell, and I should recognize some of my mental health care heroes in this room. Julia Ratty, I love you to pieces. This would never have happened without you. We started down this journey 7 years ago. Steve Shell, Dr. Woodard, Stephanie Woodard, I love you so much. But we started this 7 years ago. And so it's really something that is so stark on our streets every single day. And just to let you know, as a mayor, there is no place to take them or treat them. Yes, we have services here and there, but we are kidding ourselves if we think that we're going to be making a difference when it comes to mental health and addiction. It's something I never talked about. I lost my my brother and my sister a few years ago due to mental health, all within just a few weeks of each other. And it's something I was ashamed, and I knew the stigma, and I never wanted to shame them. But I kept it quiet for so long. And now that they're gone, I feel like I have the strength to tell their story, because they would want me to. But it's the story that I see every single day, day in and day out on our streets. And I cannot begin to tell you how discouraging it is that we have to have our loved ones arrested to get them help. And that's where I found myself as a mayor. If your mayor can't get help, who can? Who? And I know your challenges, the same ones I have every time people come to the dais and speak to you about public comment and where we're going to find the money. And if we don't, I don't know how we will ever have a healthy America or healthy cities. It's the #1 crisis, if you think about it. If you don't have your mental health, what do you have? What do you have? You have no education, you have no infrastructure, you have nothing. But yet we act like it's not even a thing. We walk past people laying on the street that are screaming in pain. And yes, if they had a ruptured appendix, we would get them help. But because they have schizophrenia or addiction, we walk over them. It's so unacceptable. So all I can say is I'm so fortunate to be here with Commissioner Garcia and Julia Ratty, Steve Shell, Stephanie Woodard, begging and hoping that you will hear us desperately when it comes to crisis services. We are standing up a 24/7 crisis service. It's a living room model. It's not a bed model where, like you see in ERs. That's not where you can treat mental health and addiction. That is just not the environment that people can thrive in whenever they're truly suffering. But I would say this, and Steve Shell, come up for a minute because you know this space better than anyone. This crisis center we've been actually working on this for 7 years, Julia? How long? 5? Well, it feels like 7. It actually feels like 70. But, and so this didn't happen overnight. It came with a lot of love and care, but data and statistics. I think Senator Donate, is that how we pronounce it? To your point, what are outcomes? What do they look like? This is something that's been studied. It's a model that's been around for decades, but it would be a shame if we didn't have one in Nevada, or certainly, obviously I'm going to advocate for my cities, but I'm speaking actually on behalf of mayors all across America. You know, it's interesting too, I would just say one last thing, because I want you to talk about the crisis care model. It's 24/7 and anyone can be brought there, or it gives officers resources to take them directly so they're not going to our jails and ERs. But, you know, we have a lot of frustration, especially mayors that don't have the support of their counties, because that's where health and human services lie. I am super fortunate because I have Commissioner Garcia, Commissioner Hill, Commissioner Andriola helping me, Julia Ratty. I'm so fortunate. Now, that's typically not how the system works. Cities don't get any of that funding, period. We don't have any resources. So we have to rely on our partners. So I'm relying on you today to make us one of our biggest partners throughout Nevada, not only for the city of Reno, but also for cities all across Nevada. So thank you. Steve Shell, please.
Good morning, everyone. Steve Shell for the record. It's great to be here today to talk about such an important topic. I want to first say that Mayor Sheevy was very instrumental about 5 years ago in meeting with Director Richard Whitley to identify space in our Reno community where we could stand up a crisis stabilization center. So we are very grateful that Director Whitley was able to identify space within our state hospital, Deanie Townsend, that has been sitting vacant for quite a while, that we are now going to repurpose as a crisis stabilization center under the license of a renowned regional medical center. So this will truly be a public-private partnership. The state of Nevada is using ARPA funds to be able to renovate the space and covering operating expenses for the first year. But I want to stress that we really have to think beyond the first year at the sustainability. It's great to stand up centers like this, but we're going to really need to make sure that they can sustain for the long haul. I don't think any of us want to stand up a new model that can't, continue beyond a certain time. So I think that's going to be really critical that we keep a close eye on that. We've worked very closely with Nevada Medicaid to create a rate for crisis stabilization centers, but none of us know at this point whether that's truly going to be sustainable or not. That's what we'll be using this first year of operation to really look at. We'll be opening our center at the end of August or early September. And as Mayor Sheevy alluded to, this will be a 24/7 center. It will serve as a walk-in center, law enforcement drop-offs, ambulance drop-offs. The goal is to truly divert individuals from the emergency rooms as well as the jails where we know these individuals do not belong. And also I wanted to mention that we're going to be staffing it with registered nurses, peer support specialists, psychiatrists, and other medical personnel to be able to figure out what the individual in crisis truly needs. Not everyone needs a bed for treatment. There are individuals who simply need, a therapist or other wraparound services. So the purpose of the crisis center is to identify what that individual needs and get them help at that moment.
All right, Commissioner Garcia.
Thank you, Madam Mayor. Thank you so much, Chair Donate and members of the committee. My name is Mariluz Garcia, and I'm a commissioner for Washoe County, representing District 3. I'm so grateful that we have so many champions in the room today, and I'm also looking forward to working with those of you in the South who I haven't had a chance to meet yet. So 26 years ago, I landed in Washoe County. I'm originally from Elko, and I remember the first job I had was working with the families of a Title I school and seeing and hearing the issues that they were facing, and this is 26 years ago. Fast forward, I can now see this topic, and I've lived it as not only an educator, but as a mom and as a policymaker. District 3, for those of you who are not familiar, is an area of Washoe County that is very densely populated. It's a high percentage of working class families. It is comprised of the most diverse people in our county. And, I've only worked with low-income first-generation students in Title I schools. And so the conversations I had as a school counselor were always very real and raw for the parents that walked in. There was concerns about housing and substance abuse in the home, domestic violence, issues with housing, and many other things that these parents walked in day out struggling with. And not only were they struggling, their children were struggling. And it was just proof that trauma can breed more trauma. And that really is the root cause. And that really is, to me, the most critical epidemic we have in this country. So I've also had the fortune to work with young adults. I really appreciate it. I don't know if she's still in the room today, but the student who spoke about the behavioral health needs that are facing our young adults who work and live at the university, challenges with anxiety, depression, substance use. So I really appreciated that perspective, and it's a population that we don't talk about or hear about very much, but I personally have seen a huge shift in our college student population, and they're starting off their adult lives with these challenges, and it's not getting any easier for them. I am so grateful to be in this role working with amazing mayors who are leading this charge, and being part of Washoe County is really an exciting time right now because we, as practitioners, saw what a huge loss it was to lose West Hills when they closed the door in December of 2021. I remember texting my colleagues going, what do we do now? It was such a huge loss for our community in Washoe County. And, you know, one of the best things that happened to me last year was sitting at the dais and voting to approve the purchase of this building that had been boarded up and a resource that had been gone for years. And we approved the purchase of West Hills in August of 2023, the Washoe County Commission. It was my favorite vote last year. And I wanted to say thank you. It was a very happy
those votes when you have them.
It was a happy spot, yes. And, you know, I wanted to say thank you to the state of Nevada for also investing in this amazing opportunity for us to renovate this building at $14.5 million recently approved. I really am so grateful and appreciative because I know it's going to be transformative with the leadership that we have with the amazing Julia Ratty. So things are looking and moving in the right direction in Washoe County. I wanted to end with, you know, the fact that my first touch point with Washoe County was through being an adoptive mother, a foster mother. And I can tell you, I know we're here to talk about adults today, but I cannot talk about mental health without talking about what happens on the front end. And, you know, without going into too many details, you know, my children did not start off in this world at the same level that many other healthy children do in Nevada. And, you know, they were, by no choice of their own, impacted by generational poverty, family histories of mental health and substance use, homelessness, you name it. And we have worked very, very hard to get them access to all of the early intervention that they need to help them heal from that trauma, to help put them on the right trajectory. And we're not out of the woods yet. And I can tell you, as a school counselor, as somebody who has a PhD in education, I struggled during the pandemic to find access to resources. Overnight, everything was gone. Our special ed team, our play therapist, our occupational therapist, our family respite, everything was gone. And I know if I struggled, I know many Nevadan families struggled, and I always bring to the table that rural perspective too. We think we have it bad in Washoe County and Clark. You should visit the rurals. It's incredibly challenging, and there's still a lot of stigma out in the rurals with accessing mental health. So with that, I just want to end by saying, you know, we really need to push that mental health is health. Bottom line, it is all connected. And I would love to see us continue to have the collaboration between the state with the counties, because to Mayor Sheevy's point, we are the Health and Human Services arm, and we want to continue to do this work, and we're really grateful and excited for this opportunity. So thanks for having me here today.
Thank you so much. As I mentioned, Councilman Knudsen is still on his way, so hopefully he makes it for the agenda item. If not, we'll just have to take things out of order when he comes through. I don't know if there's any questions. Probably through this conversation, it'll trigger some. But Commissioner and Mayor Sheevy, I don't know if I heard you guys answer it. I know I heard Commissioner Jones answer it, but again, if there's one thing, the first thing to focus to fix the mental health system, what would you fix, or where would you focus?
Medicaid reimbursements.
Ditto. Without them, we have nothing.
No, it's very straightforward. I think that's helpful for the. So this is the reason why I wanted this agenda item was as part of the legislative history that I went back and reviewed from minutes of the meetings that happened in the 90s and the early 2000s was, and this is just my interpretation of how the system came to be, was that there were a lot of cuts to the mental health system in the early 90s that have occurred nationally, including here in the state. And from my understanding, we never replaced a lot of that funding to be reinstituted just because of budget cuts. And then obviously during the 2008 recession, the state of Nevada did the same thing, where oftentimes when we make budget cuts, even as close to, the pandemic, it forces us to cut much needed programs, and sometimes that is mental health. And it's kind of we put ourselves into these dire situations, but then we never come back to fix all of them. And I think what we've learned over time is to me, it seemed like over the last few decades, we passed the buck onto local governments. And so how do we, as local elected officials that represent your jurisdictions, how do we essentially coordinate between I guess maybe let me rephrase my question. What should be the responsibility of the state versus the responsibility of local government when it comes to mental health? I think that probably is the first question. And then the second question is, how do we work together when jurisdictions have different themes or different modes of focusing on addressing this, right? If the city of Reno disagrees with Washoe County on how to fix the mental health system, one wants to build more housing, the other wants to build more navigation. How do we work together to actually address the system in its place? And so it's kind of a two-part question, and it could be for anyone.
Thank you for the question, Senator Donate. I think we have already shown that we can work together in so many ways. We just hosted a mental health summit where I believe it was the first time where we saw so many agencies come together, local jurisdictions, our elected officials, members from the law enforcement community. I think that's a really special example of how our region has come together to tackle homelessness and many other regional issues. We're historically, I think, very siloed, but in the time that I've been in this seat, I've been really pleased and inspired by the way that everybody has taken hold of this very important issue, because mental health touches so many facets of our life.
Okay, I would like to add, this is probably not a traditional answer, but I'm going to stress this, and I know I'm preaching to the choir. This is why it matters who you elect, quite honestly. And that's what happens when you elect people that truly want to get something done and work together in collaboration. That's really hard these days with, sort of the political environment. But I wish more people understood how important it is to elect the right people that care about the same things that they do. So that's nor here nor there. But the other piece of that is what I would say, especially being a city, is that it's critical to get this funding into the county and also at the city level, because we don't get it, we go to the county. So let's just say in the event we are not working together because we might have political differences, who knows, political environments change dramatically. That is not how the funding source goes. And remember, we are ground zero. It goes to the county and it never goes to the city. I would say, first of all, I want to commend all of you and whoever invited me here today. This is the first time as mayor, in the 12 years that I've been mayor, that I've ever been invited here to speak on this topic. And it makes me feel like you're hearing me, you're listening, and you truly do care. And so that's another, I think, gap that needs to be filled. I actually think that our representatives need to come maybe to council meetings or commissioner meetings before you get into session. We're doing this job every single day, 24/7, 365 days a year. I mean, there are many times I don't even sleep because it's a full-time job. And I know your jobs are, extensive, but at the city level, it's really where the rubber meets the road, and we really need that help and assistance. Like I said, I'm lucky I get to work with my fantastic partners at the county commission, but I shudder to think if that were not the case based on political divides and the political landscape we live in today.
And Senator Donate and members of the committee, I think my short answer would be that your trust in us, in the counties, is really important. To Mayor Shivi's point, we see this day in and day out. We live and experience it, and we know our people and we know our communities. So I know when the higher you climb, the further removed you can become, but if you continue to trust us and find opportunities to collaborate with the counties and the cities, I believe that is money and time well spent.
And I just want to add too, last week I was in Washington with 40 mayors, with Mayor Bass from Los Angeles. She has 46,000 homeless residents in her city. Homeless. 46,000. Being with those 40 mayors, it really sort of just, it's something that is so astonishing to that level when you hear and you see it firsthand. I went and I visited Los Angeles with her. But I would say that mayors across the country are saying, you know, this is our #1 crisis. And we just don't have the resources, especially whenever it goes, you know, to the states and then it goes to the counties. A lot of times mayors and cities never ever see that assistance ever. And think about it, it's our police force, it's our jails, it's our ERs, where, you know, like I said, it's where the rubber meets the road. I do want to say this to give everyone hope. I met with Amade, Congressman Amade, I met with Captain Cortez Masto, I've met with Jackie Rosen before, Senator Rosen. I will tell you, everyone, you are very lucky to have the representation that you have. It is truly remarkable. Even if you are on different sides of parties, they have been so accessible and so open on the federal level for the state of Nevada. It has been impressive. And many of you know I am a nonpartisan. I don't care about parties. I care about people. And both sides have been tremendous, and we should be so lucky that we have great representation there. It is impressive. I hear from other mayors, and I see other mayors trying to get into their delegations, and sometimes they have zero access at all. So everyone, when you see our delegation, please tell them we're very lucky. So I wanted you guys to know too that they are working as hard as they possibly can as well on this issue, and I truly believe they're hearing us loud and clear because they want to be able to help you as well when it comes down to how this sort of trickles down.
Thank you. Let's go to Commissioner Jones, and then our councilman joined us. I'll give him the chance to speak as well.
Thank you, Chair. Justin Jones for the record. I would say it was a philosophical question about who really should bear the burden of addressing mental health. And I would say I don't have the answer for that because there are different models across the country. However, regardless, sort of to Mayor Sheevy's point, everything that we do in local government is pervaded by this issue, substance use disorder and mental health. We have to run the jails. We have to provide public safety. We have to address homelessness. We have to assist when it comes to our schools. And mental health concerns are pervasive through all of the functions of local government across 39 departments of the county. And the same thing goes for the city. So I would say we're in it whether we like it or not. And we want to be your partners with the state when it comes to finding that dedicated funding stream so that collectively we can address the issue.
Yeah, I guess my follow-up question would be, if there are different models that are followed across the country, what's the model that you think should work? I guess that is probably the main question. And I think the reason why I'm asking that is historically there's been this conversation of like a mental health agency, right? There needs to be one authoritative figure that is deciding, okay, as the local townships, this is what you're entrusted to do. This is what the state is going to do. Here's where we're going to go forward. So I guess my question is what does the model look like, and does it need to be revised, or do we continue the status quo and we just fix the funding issue, right? I think that, to me, is probably the bigger question, but I'll come back to you on that. Let's go to Councilman Knudsen.
Thank you. Brian Knudsen. I represent the city of Las Vegas in Ward 1. I apologize for being late. I was chairing my own public meeting. Really grateful for the leadership of you, Mr. Chair, and the committee for allowing cities and counties to talk about this issue. I don't know what I missed, and so I apologize. But I would say the opportunities for cities and counties and the state to work together on this issue is imperative, and it's right now. And I would just give a shout out to your staff at DHHS. I've been working with them for more than 15 years. You have incredibly bright and talented people that probably know a lot of the answers that you're asking for. And they've been actively working with us at the city and county level, and we're working together to try to figure out what that next step is. Nevada is just different in how we fund things, but the opportunities are there, the right people are in place. And I think that to the question of what would I change about the system? And that's, I think, fundamentally the issue. I don't think we have much of a system to change. I think we have the right people and we need to build a system. It should also focus in on preventing. And so a lot of our conversations, myself and the Commissioner, have been focusing in on a crisis response, which we absolutely have to do. But we also need to split our time in talking about how do we prevent people from ending up in that situation in the first place. So I'm happy to talk through any of those questions or the activities that we've been working on the last couple of years.
Justin Jones for the record. I would say I don't know what the right model is, but here's things that you all know better than anyone that are unique to the state. We have a legislature that only meets once every 2 years. We in local government, we have to go do this every single day, and we actually get paid for it, which I know you guys don't. So I would say a response that involves the local government folks in providing those services is absolutely instrumental. When I chaired this very committee a decade ago, we worked on the Regional Behavioral Health Policy Board discussion, which ended up getting adopted in 2015, 2017. That was one piece of it. So in terms of like regional policy discussions were important, but at the end of the day, the regional behavioral health policy boards are really just recommending committees to you as policy makers, and they're not the ones that are operating the actual systems themselves. It is really a collaboration between state DHHS and we in local government to make sure that on the ground they actually happen.
Mayor Shivi and Commissioner Mariluz, I don't know if you guys have any other comments, or I know my question was more philosophical on the change of model, or I don't know if there's anything you wanted to discuss or.
Not particularly. Like, I think I was hearing you loud and clear when you said that it was hard to make this agenda because especially mental health and addiction is so incredibly broad. But, you know, and then I think Mr. Jones just raised the question, like, Nevada is very different. Obviously, it is for so many reasons, but I mean, let's really talk about, we're the only state that does it with depreciation. It's no wonder we constantly rob Peter to pay Paul to fund anything in this state. And until someone has the political will to do it and the guts to do it, funding will be continued to, you know, be incredibly problematic. I mean, if we're just going to call a spade, I just have to say that's where we constantly see it every single day, day in and day out, with every funding that we do, from housing to healthcare to education. I mean, I think we have to wake up if we really want to be bold and big and have, you know, the political fight in us. I think everyone needs to really start talking about what that looks like if we want things to change in Nevada. So that's just, I know that's the big broad view that we all have talked about when, you know, talk about it in circles. But to be honest with you, to change Nevada and stop being last on the list, that's where it's really going to happen. So sending you guys lots of strength, because I know how difficult your jobs are. We have the same job, and you know, I always said that I wanted to, I'm an entrepreneur. I have been and I own my own businesses. I always said I wanted to be my own boss. Now I have 250,000 of them. So I understand how difficult your jobs are every single day. So thank you for all that you do in your service.
Thank you. I know we have a question from Senator Nguyen, so please proceed.
Thank you, and I will just second what the mayor said. I think we do need to be bold in how we address how we are going to rise out of the bottom of all of these top 50 lists that we seem to be the best at being the worst. And so I look forward to having continued conversations about what that looks like for our state moving forward. City Councilman Knudsen, I know that you weren't here a part of this, but during the Attorney General's presentation, I had asked a question around opioid and the funds and the recommendations that they made, some of them more aggressive, some of them like smaller, but I asked if they were a part of any kind of overall strategic plan. The Attorney General had mentioned that it was his understanding, and this probably goes to those of you in Carson City as well, Do you find that your own county and city strategic plans around opioid and addiction and crisis intervention or any of those are in alignment with the state plans or other strategic plans, or are we all operating in silos?
Brian Knudsen for the record. I appreciate the question. I think it's a little bit of both. We do operate in silos to a certain extent, but the amount of funding dictates that as well. So the city's going to have a couple of $1 million, which in the grand scheme of things is not going to have the greatest impact. I've been working very closely with your DHHS staff. I think they have much greater access to funding, and it's thinking through how to leverage that funding with the local jurisdiction. So it would be great to have staff who are responsible for those decision making and staff who you trust, who can make recommendations to you, meet with staff from the cities and county to brainstorm that. I don't think the city has gotten to the point where we're allocating funds yet. We have asked for advice from groups who are responsible for opioid addiction issues because there's no expertise in the city. It relies out in the community. So if there was a bringing together of state folks to say, hey, city and county folks, I think there's a lot of opportunity. And it's not just the couple $1 million the city may get. It's future CDBG allocations. It's future how we align all of our existing resources. It's a great conversation to have. The city and county work pretty regularly on those issues in Southern Nevada. It'd be great to integrate the county or the state, excuse me, into those conversations.
Justin Jones for the record. I would just echo that. With regards to opioid funding, it's very similar to all of the other discussions we've had. It's great that we have this windfall of opioid litigation settlement money, and under the One Nevada plan, the county gets so much, and the city gets so much, and the state retains so much. We are working through our regional, our county plan on how we are using our funds, but we already made the decision or the allocation last year for this first $65 million of our county funds to go to a state world-class opioid treatment center. We still need a large chunk of money even to start construction on the facility, and that doesn't even take into consideration how we're going to fund the program going forward. And so we're looking at payer mix and other things to make sure that once we actually open that kind of a facility, it can actually serve the needs of our community for the long term.
If I can just add to that, I think that's a really good point, because the one-time money, which the opioid settlement is a one-time funding shot. It's super helpful. It's great to start something. At the end of the day, that's where we need that state integration, is understanding what the long-term implications are and the operations and maintenance of any particular service. And it's going to come in through that Medicaid or insurance reimbursement rate that allows something to maintain in perpetuity. But the one-time shot helps us to get us started.
Chair, if I may follow up, I guess my question is I know you two work together very well, but is there any kind of overall, I guess formalized communication between like cities and counties to make sure that there's overlap, or there isn't overlap in the type of resources and the type of priorities that, say, the county is taking on as opposed to the city, who may have a larger allocation of even these one-time funds? And then secondarily, I guess I'm looking, is there, I think the chair asked, is there an ideal model? Like, do we have a model? I think back to the money that we received during the pandemic, these ARPA funds, and a lot of times we just didn't have any kind of strategic plan to plug even these one-time funds into, because we were like, there's no money, we don't have the money, so we don't even have a plan for what we would do when it came in. And so let's say we are in a situation where we're able to increase and come up with a permanent funding source. Do we even have programming that's set up to like accept that like one time or that ongoing funding source?
Brian Knudsen for the record. I would answer it in two parts. Is one, I think we can't, we don't overlap because there's so many big gaps that it's almost impossible to overlap. Are we duplicative? Maybe, but there's such a huge need that it's okay. We can overlap and duplicate and still not meet a tenth of what the need is. With the question of plans, there has been a number of plans. It's easier for local governments to create a plan and follow it. What I've seen with the state in particular, not to place blame on anybody, but the state comes up with studies and plans, and to be able to follow through with them in the next legislative session or with people who are elected and have different policy goals, it may not get enacted. So a good example of that was that, I think it was maybe 83, maybe 3 sessions ago. It started out as the city trying to do a tax on sewers, and it turned into a study of what the overall arching plan for homelessness is. That was a very big document that took thousands of hours of local governments to come together and decide, that was supported by the state legislature, and then that plan still sits on a shelf. So I would push back to say it would be great if we came up with a plan and then followed through with it.
Justin Jones for the record. I would say when I joined the county commission 5.5 years ago, the relationships between the city and county were, I would say, non-existent. I won't take credit for the relationship between the city and county now. Brian and I worked very well together, but we're not alone. I think our staffs are fantastic and have, regardless of the political members of our boards, the staff have been working together for years to make sure that they're addressing the needs of our community. And I think our current boards are trying to work together in a regional way on everything from mental health to homelessness, for sure, to make sure that we're not duplicating services, and that things that may have been done in the past, like the courtyard is a good example. The city sort of went down one pathway with the courtyard, is now being integrated back into a larger system to address homelessness across the valley. And we are optimistic that, again, in terms of the legislature being creative, the last legislative session, the opportunity for $100 million that the state allocated to be matched by private funds, and mandating that the local jurisdictions all be bought in through navigation centers was a great model for you all as legislators to essentially arm twist we in local government to collaborate with one another. So I would say, Chair Donate, back to your point of what's the optimal model, to the extent that you're hamstrung by constitutional limitations, that is at least one way to make sure that we all play nice in the sandbox, is to tie state funding to collaboration.
Yeah, I think that leads to the conversation of like accountability, right? If we decide to do some funding mechanism, I mean, you threw out a few of them that other states and counties and jurisdictions do, whether it's like real property tax reform or a sales quarter from the sales tax, right? Whatever the scenario is, if we arrive to that point, not talking about the one-time shot dollars that we've already allocated through ARPA and so forth, right? Or if we have a surplus, that's a completely separate thing. But if we find a scenario where we agree to fund or revamp our tax structures, our funding mechanisms, then we want to make sure that there's an accountability for the local governments and say, you're going to receive these dollars, but now this is what you're required to do. You have to reduce readmissions. Like, there's just no denial. You're going to have to work together. There has to be a plan. And if you fail to do so, then you get the funding taken away, or you don't get an increase in funding in the next 2 years, right? Like, there has to be, to me, a plan of where do we need to go between now and the next 10 years, and are we following through? And if we're not following through, then we can focus on the subset of the system that's not working, and then that's where we can work from session to session to make sure that we're still on track to meet the guidelines of what we decided 5-10 years from now, right? I think, to me, that sounds like the bigger trajectory if we arrive to more funding. And it's not enough, I guess, to the point being that it's not enough to just say we're going to improve and increase Medicaid reimbursements. That doesn't solve anything. It just makes sure that our providers get paid more. But there needs to be a robust conversation of how does each sector of the system all work together, and that includes, to me, local governments. So I don't know if there's any other further questions. I think this was a very helpful presentation. Councilman, were you going to say something, or do you have any closing comments, any of you?
Justin Jones for the record. Just again, thank you on behalf of Clark County for making this such a priority of this committee, and we also look forward to the discussion of children's mental health, which I know is near and dear to the heart of my friend, Councilman Knudsen.
And thank you for saying that, because I was going to say that the conversation around crisis prevention, the mental health system, which the state has to be an active role player in that, it also allows for us to talk about prevention services and what do we need to do to prevent the next 20 years of looking like it has the last couple of years. I would also just argue, if you haven't had the chance to do a ride along with a police officer in Metro or a ride along with the fire department, it makes it much easier to understand what the implications of a lack of a system has on our Southern Nevada community. I'm sure this is true in Northern Nevada as well, but if you do a walk through an emergency room at UMC or Valley or any of them, if you do a ride along, you'll see firsthand what the impacts of a lack of planning around has on our first responder system. So if we can get to the point where we're thinking about the future as well as addressing the current state, I think we'll be in a much better place. And I know we serve as active participants in the process, so thank you.
No, thank you for that. I have done a ride along. I did a full shift, and it was incredible just what you learn just within this short time frame that you're with them. So I think that's definitely something that we need to obviously cater to. So, but I appreciate, of course, the work that you all do. I know it's tough working in local governments, and there's issues that sometimes it feels like we're putting one fire out and then we move on to the next one, and it just feels like it adds up. But hopefully we can work together to the point that we can at least fix some of it and we can focus more upstream. And Councilman Knudsen, I'll invite you back to the next one when we have in June when we talk about children's mental health, because I would be eager to hear your recommendations. Okay, we'll go ahead and close this agenda item. Thank you to our elected officials from both Northern and Southern Nevada. We'll go on to agenda item number 7, which is an overview on access to behavioral health services for adults enrolled with Nevada Medicaid and policy considerations for behavioral health continuum of care. With us, we do have Administrator Weeks from the Division of Healthcare Financing and Policy, so please begin when you are ready. So just as a quick point, after this presentation, the committee will go to lunch, and then we'll continue on with the following agenda items. But Ms. Stacy Weeks, please continue when you're ready.
Mr. Chair, Stacy Weeks for the committee, Division of Healthcare Financing and Policy, and Nevada Medicaid Director. I hope you guys can see the slides. I'm not very technology savvy. I did pull it up on the laptop, so just want to make sure folks have that in front of them. Thank you for having us today. It's been definitely an interesting discussion and very much appreciate the focus on this topic. It is a very big need for Medicaid and our recipients. I think a big theme so far has been money, and we'll talk a little bit about that. But I do think there are a couple other things that, as a policy committee, it's worth noting and talking about that could be helpful to improving access for behavioral health services. So with that, I'm going to dive in and move forward. So real quick, I am going to touch on some stats that we have. I think it's really important to inform our conversations with data. We have a lot of data at Nevada Medicaid and the Office of Analytics, which is housed under DHHS. I think sometimes we report a lot and we admire the problem and we don't take a chance to look at that problem. I'm hoping today we can look at some data and to start thinking about how some of the things we already report on could be useful to your committee going forward. I'm also going to give you guys a preliminary rate review finding from our quadrennial rate review. Very excited that our team was able to do some initial data for you guys so you could have it here today. And I think that will be really helpful for conversations around where we could focus some new investments on rates. And the other thing I want to talk about is gaps and opportunities in Medicaid. We have a lot of, I like to think of gaps as opportunities, but sometimes they are just gaps, and I think they're worth noting here today, but I think a lot of them could be opportunities for next session and just generally working together on these issues. And then I want to talk a little bit about workforce and access issues, because rates are not the only problem in our state impacting access. And then again, at the end, I want to touch on, I think, Medicaid's role in this, as you guys know, is a really big player in Medicaid financing for behavioral health. Oops, I am not doing this right already. Okay. Behavioral health stats. So the first thing I wanted to give you guys kind of a quick overview is who in Medicaid right now that we have data on for who we consider as diagnosed with serious mental illness. Thank you. Thank you. Now it's normal. Yeah. Okay. Awesome. There you go. Okay, thank you. Boom. Oh, boom. Yep. that one. Okay, thank you. All right, sorry about that. For serious mental illness, when we look at the program today and we look at all, so right now we're focusing on adults on this slide, and we look at all adults, so that includes seniors, so over 65 that are in Medicaid. 1 in 7 people on Nevada Medicaid have a serious mental illness. And of those, almost half of those have an SUD, a substance use disorder. About 10% of those with SMI, which is the serious mental illness diagnosis, have what we consider opioid use disorder. And about a smaller percentage, but worth noting, about 2% of this population also has autism and or fetal alcohol syndrome. And this is for adults, so this is 21 and older, all the way to the end of the life cycle. Now, when we look at national stats, you might hear 1 in 4 adults, and that's because, and it's true for Nevada Medicaid too, because when we only look at those 21 to 64 years of age, it is 1 in 4. So that is actually on par with the national data of what we know in terms of Medicaid enrollees having a mental health disorder or serious mental illness. So again, it's 1 in 7 when we include the seniors, but it's 1 in 4 on average when we consider just adults up to age 64. All right, I'm going to try to walk you guys through these slides. It can be a little confusing with some of the acronyms here, but just wanted to give you guys an overview. When we look at the number of people in Medicaid currently with diagnosis, I just want to also point out before we dive in that often what we know about this population is that they are struggling with mental health issues, but they are not quite yet screened, assessed, and diagnosed, right? So these are just numbers of people who we have the diagnosis for. So I think that's an important point to remember, that there's probably a larger percentage of folks in our population that have not quite yet been screened and diagnosed for mental health, and they are not quite yet getting treatment and services. So when we look at the population, the majority of them are our families. So our parents that are some of our lowest income families. So about 63% of the total population is our parent population, and they are on our cash assistance program. They're also struggling with employment and keeping jobs, and often mental health has a big role in that. So I think that's important to remember, and that's why often many states are looking at adding employment supports as a part of Medicaid-funded programs through waivers and things like that. And then also 20% of this population are our seniors and blind and disabled population, and another roughly 18% are what we consider our expansion adults and parents who we added in Nevada with the Medicaid expansion feels like many moons ago, but it wasn't that long ago. I just want to note too on that expansion, that 20%, that is actually a much lower number than the national number. So we're going to dig into this data a little more because I kind of think we might be missing some folks in that category, because what we do know about our expansion population, this is usually our adults without children who are homeless. So I think either we have not quite identified them and diagnosed them, as could be the indicator here, or we may not have the full number here. So I just want to note that that number is lower, and we are looking more into that. And we look at spending as a whole of our pie. Just a reminder, Medicaid is partially state funded for our state general fund, and the rest is federally funded. And we draw down that money not like a grant. We draw it down on the actual service being used for the recipient. So that money is tied per claim when we have a service that has been received. And we look at that right now currently on utilization and actual spending. It's only about 4%, right? So we kind of, since 2021, it was 4.5%. I think you saw that drop a little bit here because of COVID, potentially some other things that were going on. And then now we're picking back up in 2023 at 4.4%. And so the total spending is about $4 billion, as you can see here on behavioral health services. Sorry, is that 4 million? So maybe that is 4 billion. I'm sorry, I haven't had enough coffee this morning. But as you can see, I think that pie, there definitely could be an increase in spending if it is at 4% today. All right, I wanted to walk us through a little bit of the behavioral health care continuum, just to kind of ground us in what we're talking about. Because everyone's saying we need more, but what do we need more of and where? So when we think about the behavioral health care continuum, just broadly speaking, there are really these 4 service categories. And the first on the left here is the early identification intervention part of our system. This might be our primary care clinics, this could be our schools, this could be any area where someone comes in contact with the system, healthcare system, state or county system, and is screened and diagnosed or at least identified for some sort of assessment later down the road. I think this is an area you've heard others talk about today. We need a little more work in this area. There's something we're trying to do on the children's side, more with schools, and we can talk about that in a future hearing. But I do think there's probably more opportunity here that we haven't quite actually captured yet in Nevada fully. But this is really our low intensity area of our service, and typically our lower cost services fall in this category. As you move to the next bubble, this is someone who has been diagnosed, hopefully, right, and identified, and then they're moving into what we consider our outpatient and community treatment. And this is where we want people to be. We want people to be able to get the behavioral health services they need, therapy, treatment, medication management, whatever they need in their community in an outpatient setting. It's not only cost effective, but it's the best place because then they can still function in our society, right? This is where they can still live and function within the community. Sometimes, though, things turn into a crisis or we have an emergency response, and that's that next bubble there. This is our crisis stabilization, mobile crisis. This is our sometimes leads to inpatient services. And, you know, people sometimes cycle right back and forth between outpatient and crisis. And then some people go straight to crisis, and that's where we're identifying them. And that's when I think you know the system has failed somewhere, right? Someone did not get into their primary care clinic. Someone did not find a way to get diagnosed early and treated early before they ended up in a crisis. So that's something we, you know, try to think about as we are building our system, is trying to get people services earlier to avoid some of those costly crisis situations. And then some folks end up in our residential and inpatient treatment. These are folks that end up in our psych wards at the hospital, or also in what we consider institutions for mental disease under federal law, which is our residential psych centers. Currently in Nevada, we do not cover services with Medicaid dollars for serious mental illness in a residential treatment center. And this is anything that qualifies as an IMD, which is more than 16 beds. We are seeking an amendment to our waiver where we cover substance use disorder treatment in a residential setting. So we will be adding these services hopefully soon. I can never predict CMS, so if I had my magic 8-ball, it probably would say at least 9 months to 12 months, depending on how long CMS takes to review our amendment request. So that's something we're working on. But again, you know, we really want to keep most folks in those first 2 buckets, right? So that's where we not only see better outcomes for people, but also less cost to the system and less expenses. And then just wanted to note too that the more we put people, the less we have in our community to support people, the more we put ourselves at risk for a Department of Justice finding for our adults as well. We currently have a finding for children that we do not have enough services in our community to avoid institutionalizing people or children with mental disorders. And that any state that does not invest enough in that outpatient, in that community service, also risks that finding as well. So just wanted to point that out. And that's because the Americans with Disabilities Act, all states have to try their best to provide the services that people need in their communities. All right, moving on to some data around access. So I don't know if members may know about this, but all state Medicaid programs must report and, well, first they must monitor and track access metrics and report those findings to CMS. And each state's done it, unfortunately, a little differently, which makes it hard to compare across states. CMS recently released a very lengthy rule, I think it was last week or 2 weeks ago, on the access report, and is really increasing our requirements for tracking access. And you'll see some items, hopefully next session, for Medicaid to do this work. But they're really holding states to a higher standard around access. And, you know, often this is not just about rates. It's really making sure that people have access, not, you know, in the rural areas as well, so not just in urban areas. As you can see on that table, so if you look at that chart, as you can see the line is dropping there, that's the number that we've been tracking of enrolled providers in Medicaid for behavioral health. And it's a pretty big group of providers. I've listed them there at the bottom for you that are included in this breakdown. But as you can see early on, during COVID, we were up to about 6,000, a little over 6,000, and we've slowly started dropping during COVID. I think, a lot of this reason could be people were not seeking services during those times, and other, that also affected businesses and finances for providers. We did see it pick back up a little bit and then drop back down, and now we're seeing it drop even more at about 5,860. There are other reasons besides COVID. There could be rates. We talk a lot about that. But it could also be some of the issues we've had with fraud in this area. That is the unfortunate part of our work at Medicaid, is that while we want to be flexible and remove every burden in the world for providers, we also have a lot of fraud amongst providers, and behavioral health providers, unfortunately, are one of our biggest areas for fraud. So there have been a number of folks that we have closed in the last year around fraud, and it's significant, and it's an unfortunate thing because it has an impact on our program. It causes us to not be so flexible on our requirements like prior authorization and other things. So those bad actors really do have an unfortunate impact on how we run our program. But it's an area we definitely want to make sure that is not occurring. So that there also has impacted the drop, but also some of our behavioral health providers did not revalidate. And that's a part of the system where every couple of years people have to re-enroll as a Medicaid provider. We make sure they still meet all the requirements and licensure requirements. And we did have some folks drop off, but we are seeing people pick back up once they realize that they did not revalidate. So we're hopeful that that number maybe plateaus out for the next year, or maybe increases and does not continue to decrease. On the far right, you can see at the table we have the number of providers by county. As you can see, in 2 counties, there's no behavioral health access, Esmeralda County and Eureka County. You can see Clark County, no surprise, the largest number of providers enrolled are in Clark County, and then Washoe following suit at 966 providers. All right, so more data, sorry, a lot of data for the morning. But I wanted to show you guys some other data that we do track for CMS. And, we often report this data and don't take a dive into it. And so I think it's really helpful to have hearings like this so we can talk about what does it mean and what is a provider to patient ratio supposed to look like for these services. I did do some research on my own. I will tell you there is no standard. There's no standard for us to pluck out of the national best practices. But when you do think of a primary care physician, 1 to 1,000 patients, one provider for 1,000 patients does seem high, but that's the one that many states are going with. But when we think about behavioral health, and patients' needs, they're not going in once or twice a year, right? They're going in more often, which makes that workload higher and more. So to have a high patient load for one provider is a lot when behavioral health needs do need more touch points with the patient. So when we look at these numbers, you can see for substance use providers, we have some of our worst provider to patient ratios in our rural regions, right? So that's something to note. And then CCBHCs, one provider for every 84,000 individuals, right? So that's just not enough in Clark County, for example. Clinical psychologists, some of the worst provider to patient ratios are in our rural regions. Same for psychiatrists. Outpatient treatment, we have, looks fairly good actually in Clark County, surprisingly. But when you look at Washoe and rural regions, we are one provider for every 1,000 patients. Clinical social workers, worst in our rural regions, and same for marriage and family counselors and clinical professional counselors. There's some, gaps there in the rural areas, and that's why telehealth, I think, is such an important piece. And not only just covering it is important in Medicaid, we often add a benefit or we cover something and then no one takes it up. And I think a big piece of that for telehealth is access to broadband, wireless, but also access to the equipment that folks need to actually be able to communicate with their provider through telehealth. One other thing I wanted to note here from a policy perspective, for the committee is that something we are starting to do, and something for you guys to think about if you have legislation next year on these topics, is that we're starting to do bonus payments or tiering payments in a way where we're encouraging rural access. So we pay a little more for a rural visit. So hopefully someone will actually drive out there in some cases, or at least want to serve our rural region. So something, just want to throw that out there, is that our payment models can be used to drive better outcomes in our system. All right, so we did want to provide folks today with an early glimpse at our preliminary quadrennial rate review findings. And this time we did do a look at some of the top behavioral health provider types that we pay currently in the system. The first one here we call our qualified mental health professional, but this is our nurse practitioners, our APRNs, our psychiatrists, our doctors, our PAs, clinical psychologists, CPCs. These are all those folks who are licensed and are, that work with the behavioral health population or mental health population. And then the second one here is our qualified mental health associate. This is our RNs, those that have bachelor degrees or associate degrees and work in mental health. And then our behavioral health aides are our high school diplomas, typically, or GEDs, but also are supporting our mental health associates and professionals. And then we also looked at rates for clinical social workers, marriage, family therapists, clinical professional counselors, day treatment models, psychologists, targeted case management specific to behavioral health, as well as behavioral health rehab treatment. And we did look at applied behavioral analysis. As you guys may recall, last session, we did have some rates that were changed for ABA, but that did not include psychologists. So this is looking at the psychologist perspective for ABA rates. Just want to point that out, that this is not duplicative of what you guys already funded and addressed last session. All right. I hope you guys can see that. I know it's really tiny, so I'm going to try to walk you guys through it kind of high level and just hit the real big high points here. What this chart here shows is that for each of those provider types, behavioral health provider types, we looked at all of the codes that we cover, and basically these are what we consider our service components, right, of a benefit. And so we will pay providers for these under these codes, and we compared those codes to other states. I want to say we looked at 10 other states. And it's often hard, though. I just want to point out, it's not always apples to apples when we're looking at other states. Other states pay for things differently. They may bundle a rate. They may pay for it 15-minute increments, and we do not. So sometimes it's not an easy apples to apples comparison, because every state really can do what they want when it comes to Medicaid. Again, Medicaid is different than Medicare. Medicaid is really ran at the state level. But we were able to look at most of these services and compare to other codes and rates at other states. So we look at qualified mental health professionals. Again, this is our high-level professionals, our psychologists, psychiatrists, and others that work in this field. And when other state rates exceed our rates for this provider type about 65% of the time. And then we look at qualified mental health associate about 53% of the time. Other states' rates are higher. When we look at behavioral health aides, though, those are the ones that we saw some significant differences. About 80% of the time, other states pay a much higher rate. So I just want to point that one out as being significant on this list. Licensed clinical social worker, about 51% of the time, other states are paying higher rates. And same for marriage and family therapists, and the same for clinical professional counselors. Now, when we got to the day treatment model, it was interesting to find that other states are at or doing better, or we're either at the same rate as other states, or we are doing better than other states. So there were no findings here for any need for an increase there. Now, I will say, when it comes to children, this is an area we probably will be wanting to invest more, and we can talk about that in the next hearing. As you guys know, with the DOJ, we're really trying to increase more of that community model. So we may be looking at that population for day treatment to try to help families in the community more. But it's something to consider that other states were roughly on par with other states at the adult population. Psychologists, we are at or doing better. Sorry, I misspoke. Psychologists, 65% of the time, other states are paying more than we are. When we look at targeted case management, we're at or doing better than other states. So that one, we do not have a recommendation to increase rates. Behavioral health rehab treatment, 72% of the time, other states are paying higher. And then the last one for psychologists that do ABA, 70% of states are paying higher than we are. All right, so now where the rubber meets the road, right? So how much does it cost? So when we look at actually trying to increase rates up to where other states are at, we did not look at decreasing or anything of that nature. At this point, we all know behavioral health is underfunded. We all agree with that. But if we were going to ask the state to give us more funding to get us where we need to be, it would be about $18 million state general fund. And I know people talk about sustainable funding, and trying to find that funding, but truly the state general fund is the sustainable funding. It may come from taxes, it could come from other places, but that is the hard decision that you guys all make and that we do not. But I just wanted to point out that that's the amount we would need to at least get up to where other states are at. It's about $18 million state general fund, which would be a full investment of about $54.5 million. With the federal dollars. I just want to point that out. The feds pick up a big portion of this at about 60% or higher, depending on the FMEP rate. And so, like I mentioned, there are levers to getting that funding, but it does, for Medicaid, it does need to be ongoing. It cannot be one-time funding, or CMS will not approve federal funding. All right. Sorry, I know we got a lot here, so I'm going to try to move quickly. So like I mentioned earlier, we have a lot of gaps in Medicaid, but we are not alone nationally. But when we do look at rankings, we are, like others have mentioned today, we are at the bottom 10 when it comes to mental health access. I think it's important to remember that, we're not the only state struggling to meet these needs, but we are not doing well. And I think as a state, that's something Medicaid takes seriously, and we are definitely trying to improve our policies to make things better, but there are challenges to doing that, and a big piece of that is funding. The first opportunity here, even though it's a lot more work for my team, is this new federal access rule. I think there's some real opportunity for not only better finding access problems, but actually being required now to put money in this direction. So I think as we dive in and digest this big rule, we'll be coming forward with recommendations from that and addressing access issues, especially in behavioral health. Another one here I have on the list is community paramedicine. I think this is an area it's ripe for improvement. We do have a community paramedic program that we fund in Medicaid, but it has not been taken up and used like other states. Several other states have this type of program, and it's really been helpful for behavioral health, especially in rural communities. As we look to trying to meet the need and keep people in their homes, community paramedics and other states are doing this work. And so we're looking at this program and trying to figure out, is it just the rate that needs to be improved, and what else we can do to make it easier for these providers to bill for services and to provide them, especially in our rural communities. Another one we need to build is the Assertive Community Treatment Program in Nevada. That's something I think is an opportunity. I think if we paid more funding and actually fund it appropriately and then actually build a full model, this could be a really helpful program for our state and help offset funding that's already being used at the Department of Public and Behavioral Health. And then the other one here is first episode psychosis. This is another model we do not fully fund or even completely cover, and it's a model I think we do need to look at expanding. Peer support services are other opportunities we have. We are right now working on increasing rates for these services as part of the Children's Behavioral Health Transformation, and we are looking at expanding it to family and youth peer supports. So that's exciting. We're hopefully moving that forward here soon. And then another area we've heard a lot about, and we know that our rates are very, very low, is for occupational therapists. That was from a prior quadrennial rate review, but a big piece that we've seen in other states is using OT for mental health. And they do a lot of different therapies to help children and adults stay in their homes and their communities. Project ECHO is another opportunity in looking at how Medicaid could support Project ECHO and get approval to fund Project ECHO, especially around areas that get at our access issues like primary care. Psychiatrists would be a big one to help us screen people at their primary clinics and then support primary care providers in supporting patients with mental health needs. Mobile crisis response, I think you've heard today, and you'll probably hear it time and time again. We need to really look at this system fully and put more money into it. I think Medicaid, we are doing a lot of work in this area now, but there's always room to grow, and I think more room for money to be invested in that system. Mental health services for adults in residential settings, like I mentioned earlier, we are working to get that amendment into our 1115 waiver so we can cover these services, which will help a lot of our inpatient psych and our residential treatment centers for adults. Housing supports and meal supports. This is another area we often forget, right, that people have other needs that impact their health. Housing, as you guys know, and meals. Especially around homelessness. And one of the things we're going to be adding into our waiver is some permanent funding and support and authority to cover these services broadly. Right now, we are adding them into our managed care program, but we do need them in our fee-for-service program, so we're looking at adding it through the waiver. Crisis stabilization services, we are, fingers crossed, I'm going to get a federal approval here soon. I feel like we've been waiting a very long time for this one from CMS. That's the other thing I think we often get stuck with is, you know, things get passed and it takes us over a year or two to implement them. And that is really unfortunate, something we are trying to work on. But like crisis stabilization services, we have been waiting for some time from CMS. Home and community-based model for adults. We are working on a home and community-based model for children, as you guys know, for the children's behavioral health work we're doing under the DOJ settlement agreement. But one thing we have not talked about and we need to think about, which is why I mentioned the ACT program earlier in community paramedics, is really how do we keep adults in their communities and out of our ERs and out of our residential treatment centers, and some service models there. And then the last but not least, you heard A.G. Ford earlier mentioned the need for coverage and services for incarcerated adults and our juveniles in our justice system. We are working right now to implement this. This is a huge lift. We just got a vendor underway and we kicked off the project with Manette Health. They are the ones that helped California do their waiver for the incarcerated adults to implement that coverage, and that will be covering a lot of our mental health services and other care for people in the correction system, and up to, I want to say 90 days pre-release. And then for juveniles in our justice system, this is a new mandate from the federal government that we need to cover services for juveniles, so they will be eligible for Medicaid while they're in the system for the first time ever, but only for that first 30 days pre-release. So we have to get in there either with our care coordinators or our managed care plans, get in there and help children access services not only in the justice system but when they leave, and so make sure they have got their appointments set up and all their medication managed and ready when they're released. All right, last but not least, or I think we're getting close. Oh, okay, we're almost there. Medicaid's role in all of this. I wanted to just point out real quick, generally speaking, on the right side here, when we think about payers and often providers coming to the legislature, and we all know this, everywhere in healthcare, there's not enough money, right? And so I think it's important to remember Medicaid is your second largest payer in the state. Medicare is third. Medicaid is about 21% of the payer mix. So if a provider takes a lot of these other types of payers, there are other areas. But when you think of what the state has levers to improve, that employer bucket there is really hard to touch, right? Unless it's our public employee benefit plan. ESI, which is employer sponsored insurance, is federal. So it's really hard to impact that large payer there. The other area is that Medicaid bucket, which I mentioned. Medicare is one you cannot touch, right? That's also federal. Military is federal. Individual market is our private insurance market, it's our exchange. That is an area, you can have an impact in with the insurance laws and mandates. And then the uninsured bucket, obviously, is uncompensated care, and we still are roughly about 10 to 11% uninsured in this state. But one thing to note about behavioral health that is different, because sometimes providers come to me and I'm like, well, what is Medicaid's makeup of your payer mix? And often it's 15% or lower, and I can increase my rates all day and it's not going to improve their salaries, right? But when it comes to behavioral health providers, especially our high intensive service providers, it is primarily Medicaid that they rely on. So I think that's important to remember. And when we think, and that's because a lot of times people with mental health needs are our populations that are struggling with employment, struggling with homelessness, and they are on our Medicaid program. And also private insurance is less robust in covering especially our high intensive, high cost services like residential treatment, inpatient psych, and those types of services. And there's a lot more limits in that area. Let's see if there's anything else. And then also just wanted to note that one thing that's, not only just putting money into our program is important, but reminding all of us that when we put money into our program, that we're getting the outcomes that we want to see. So just not increasing rates is the solution, right? We need to drive policy with our rates, methodologies. We need to make sure we've got quality. We cannot overlook quality because we're desperate for providers. And I want to always just remember that, and it's really important. And that's where we get away from our fraud risk, and also we ensure that people go into these centers and get good outcomes. So that's something I just want to note, that it's not just about increasing rates, it's about making sure we do that in a way that's going to drive the outcomes we want to see. All right, I think this is the last one, Mr. Chair, and then I'll open it up for questions. So I thought it would be amiss today if we just talked about rates, and mostly because, states have done studies, we can put money into the system, and it doesn't always solve the problem, especially right away. I'm not saying that behavioral health is not underfunded. I think Nevada has room to grow in this area. But I do think we have to think about our workforce and what else can we do to help our workforce, increase the workforce in our state in behavioral health, but also not only increase it, but look at the ones that we currently have here, the ones that are not taking Medicaid, and figure out how do we get them to actually serve this population. Rates is one piece of that solution, but there are other challenges to, I think, being a provider in this area. So when I think of improving access, I think of a three-pronged approach. The first one is, like I mentioned, the biggest is finances, right? And that is, you guys hold the purse, and that is a big piece of this. And Medicaid rates, like I mentioned earlier, are a big piece for our behavioral health provider system. But just because we increase the rates doesn't necessarily always mean that every system is going to increase salaries, and bonuses for these providers. So I think that's important to note. We can increase rates, but doesn't necessarily mean that we are increasing the salaries for providers. Also, the state economy is a big piece to attracting business and attracting providers into our state. And then just other payers and any restrictions that they have and how they pay for these services should be noted, because not everyone is on Medicaid. Our other big piece here, I think, to remember as a policy committee is our practice and licensure laws around workforce. Reciprocity laws are one area other states are looking at to increase providers coming in and providing services, and trying to make that easier. So if someone is practicing in another state, that their license is reciprocal in this state, and removing any of those barriers to doing that. Another area that states are looking at is the timeline of how long it takes to get licensed, and making sure that it's, obviously we want quality providers, but removing any unnecessary burdens in that process. Another one that we're working on is credentialing. We are currently implementing at Medicaid centralized credentialing, so providers do not have to go through 4 different credentialing processes to become a Medicaid provider. Right now they do. That once we have this up and going next year, providers will only have a one-stop shop for getting credentialed. So I'm hopeful that will help in getting more providers enrolled with Medicaid to provide these services. And then last but not least is our workforce pipeline. We have a good relationship with our universities, trying to make sure we can really maximize residency programs, but not just for physicians, for other providers, and really looking at loan repayment is an area where other states are really driving a lot of their funds and investments, and not just loan repayments, but having loan repayments with strings attached and making sure people stay and serve a community long enough or they owe their loan back to the state. And then looking also at in-state residencies that are focused on our largest gaps. So not just doing residencies for specialists, but looking at residencies for certain areas. Like if we need behavioral health providers in a certain area, focusing on funding residencies like for psychiatrists, clinical psychologists, as well as primary care providers to help screen and identify patients earlier. And with that, I think I am, I'm at the end. So I'll open up for questions.
Thank you so much, Ms. Weeks. I think, congratulations, you probably got the most questions out of everyone. I have like a whole range of sticky notes, so
Yay!
I know we have a lot to go through. So let's start with the first basic one, the one that I asked everyone from this committee who has presented today. If there was one thing that you could focus on to fix the mental health system, what would you fund first or fix first? Maybe that can start the conversation for our legislators today.
Mr. Chair, committee member Stacy Weeks for the record, that is $1 million question. I think sustainable funding for behavioral health, not just for for children. We do have some of that now with the provider tax for the hospitals, which is amazing and super helpful. But I think more of that would be very helpful to address these rate issues that we have. I think starting there is the first step. But again, it can't be the only thing that the state does. We have to look at the full system.
Oh, I think that's helpful, and I want to commend you. I think your comments were spot on with fixing Medicaid reimbursements, and I've had this conversation with so many of our providers before. Fixing Medicaid reimbursements is not the end-all solution. Like, just by fixing it doesn't mean that our problems are going to go away. It's a systemic focus that there are different parts of the system that need to be fixed, and it's not just financially, right? And of course, now that we have the provider assessment fee, like help is on the way, so let's make sure that that is implemented correctly, which your office has thankfully take the lead on. So I'll stop there. So I'll let my committee members ask questions, and then I'll round it up. But I'm limiting it to 2 questions if we can try. So let's start in Southern Nevada, and then we'll go to Assemblyman Gray. So who wants to go first? Assemblywoman Brown-May.
Thank you. Thanks very much. Ms. Weeks, first I have to say thank you for a really great presentation this morning. I love the data, right? It's really important to wrap our heads around how big the issues are here. Your Medicaid gaps equals opportunity, slide number 11, really, I think, points us as a committee into a direction where we have an opportunity to move into some solutions. So really just a statement, thank you so much for your hard work and your dedication to our state and the work that your team does. My question, I want to go back to Attorney General Ford's presentation earlier today, and the question that I asked at that presentation. The recommendation that came from the Surge Committee, if I'm saying that correctly, recommendation number 1, was for DHHS and the Department of Public and Behavioral Health and the Bureau of Behavioral Health, Wellness, and Prevention to double the amount of investment into a primary prevention program by an additional $12 million. Knowing that you are the Department of Healthcare Finance and Policy, DHCFP, and many of the funding models are going to come through your division, have you engaged in those conversations relative to the proposals that are coming out of the Surge Committee? And well, let's just start there. Do you feel like, have you all had a conversation about this?
Mr. Chair, committee member Stacy Weeks for the record. I have not, but my director may have, so I want to follow up with him. But I have not been at those tables, but I definitely think funding and prevention, but I have not looked in detail at what that means and what types of opportunities that means for Medicaid. But I do think that's an area we need more help in and more investment from the legislature.
Thank you for that. So knowing there are a number of recommendations that are coming from lots of different parties, and we're all working toward the same solutions, right? Mental health, public and behavioral health. How do we stabilize in a crisis situation? I would just really enjoy the opportunity to follow up with you all in your division relative to the recommendations that will go into the next biennial budget as we prioritize how do we address the crisis prevention. So thanks for that response.
Let's go to Assemblyman Hivitz.
Thank you, Chair. Ms. Weeks, I'd like to draw your attention to slide number 7, where it says provider to patient ratios. During your presentation, you used patient ratios and people ratios. So I'm curious, is this provider to patients or provider to people?
Mr. Chair, Committee Member Stacy Weeks for the record. I think it's people, so it's not just the ones that are utilizing services.
So this is a ratio of, let's look at CCBHCs in Clark County, 1 to 84,291. That would assume that every person in Clark County is at some point going to need to use the services of that provider or one of those providers. Is that correct?
Mr. Chair, Committee Member Stacy Weeks for the record. Let me just put it this, sorry, make sure I answer your question correctly. This is the folks that we believe would be accessing these services since they have a diagnosis. And so these are the folks that per provider would not, how many that they would need to see. Does that make sense? So for everyone, there's going to be like 84,000 people with that diagnosis or potential need. And I can follow up with you if you want the whole report, and maybe that will probably answer the question better. I apologize.
That would be wonderful if you could send that to the committee. Thank you.
Thank you. Assemblyman Corlo. Oh, okay. Senator Nguyen, do you have any questions?
Thank you for your presentation. It's always incredibly thorough whenever you get up and speak at the table here, Ms. Weeks. So thank you about that. I'm looking at the payment models, and you had talked about bonus payments that you are starting to institute. And then I'm looking at some of these preliminary rate review findings and kind of recommendations on where we need to go and what the areas where probably is there the most need. And then you had also mentioned, in the mental health area, so much of it is occupied by the private sector. I think you said it was about 15%. Is that correct?
Mr. Chair, Committee Member Stacy Weeks, I apologize. I was referring to if other types of providers come forward often, not behavioral health. Typically it's 15 to 20% of their payer mix, but behavioral health is largely Medicaid because the population is so, the needs are so great and they're often struggling to keep employment and other needs. So I think, sorry about that if it confused you.
Okay, that's what I wanted to clarify. I think I misunderstood initially, but that's what I thought it was at first. So I guess my question is when, let's say we were to institute, let's say these rate increases were to be included in the budget proposals and the budget that are passed, what kind of accountability measures do we have, or what kind of metrics can we use to show that those increased rates, I guess, what's the ROI on things like this? Is there a way to, quantify that?
Mr. Chair, Committee Member Stacy Weeks for the record. That's a really good question because I think right now we don't do that. And one thing I would love for us to start doing is looking at, after we increase significantly a set of rates, did it increase utilization? That we track. And we could specifically track for these providers utilization increases. We could look at by region, even age. There's ways to see if it worked. And then it's also, we could look at doing quality metrics for these certain types of providers, especially those on those high intensity services, to see, are we getting the outcomes that we want to see? And then we could, tie additional pay bump. And that's sort of what we're doing with the children's behavioral health, for example. So for our residential treatment centers for children, we're looking at flattening that rate up to everyone knows they're getting $800 a day for these children. But hey, if you serve our the children with the most complex needs, we're going to give you an additional 100. But then if you also meet certain quality metrics, we'll give you an additional 100 on top of that, right? So if we see, I think my point earlier was not just, incentivizing, but really rewarding providers that are doing it well. So we're putting the money in a way where we're going to drive the outcomes we see, because often we put the money in and we're not, getting the outcomes we see, because sometimes the business model is not set up to incentivize what we want. So I would really encourage this legislature to think about that when we're doing a rate increase. So are we trying to drive better rural access, for example? Then let's fund it that way. Or are we trying to make sure that the outcomes that we have or the quality metrics that we're tracking, that these facilities are meeting that, then let's pay them a little more for that, right? So that's how I think a way to really invest would be a wise way to do our investments going forward. But we could track the ROI if lawmakers would like us to. That's something I think would actually be really helpful to see if it's working.
So if I may follow up, Chair, and that's something that I'm really passionate about, is to figure out what we can do to actually see results in these areas. So I appreciate that. So you said that you were starting to do that with these bonus payments, looking at these quality metrics. Is that something that you just decided to take on in this particular instance? Does this exist within other Medicaid rates, or is this something as a legislature that we would need to mandate? What do you need? Quality metrics teams? Do you need individual people that are associated with these to track this data and report this data? How would that, what would you need from us as a legislature to make sure that we had accountability for the dollars that we're spending?
Mr. Chair, committee member Stacy Weeks for the record. Well, the current program that we're doing, just to answer your first part of your question, we're doing it as part of the response to DOJ. We did go to IFC. It was in April for some funding, and that included those bonus payments. But that was really is a page taken from other states, where other states are really making sure that if they're going to put these significant investments in to the system, that you're going to see the outcomes that you want. So that's where we started, through that new funding opportunity as part of the private hospital tax and the work we're trying to do to address the DOJ issues we have for children's behavioral health. But I think for adults, if you guys wanted to see more of that, to have a couple management analysts that we could use, right, to track these dollars, we could definitely do that. I don't think it would be a significant large team or anything like that, but I do think a couple more would be fine, but not for every rate increase and quality metric. I think just one or two, but right now we're doing it, like I mentioned, as part of our children's behavioral health work, and I think it's something we need to continue to do because I think, as you guys know very well, dollars are limited. And, I always try to remind people we're not a bank. We don't have a lot of money as a state either, and we have to be thoughtful about how we spend it. So if you wanted to put that in legislation, it would help drive that and ensure that we are building that into all of our work. So I think, especially for provider types like behavioral health, it's one that I think would be helpful to see the outcomes that we're getting.
Thank you. Let's go to Assemblyman Gray, who's joining virtually.
Thank you, Senator. Good afternoon, Ms. Weeks. I think Assemblyman Hibbett's pretty much hit on the head that I was going to bring up. That's, I don't even know if that's a per people ratio. I'm wondering if that's a per capita ratio. That provider load to patient load would be wholly unsustainable. So I'd like to see that report as well, if possible, because those, having been in healthcare, I just can't see that being a realistic number at all.
Mr. Chair, committee member Stacy Weeks for the record. Yes, I'll get you that report, but that's one of the reasons I wanted to show it to you, because I think it is super unsustainable. We need to have a lower number of patients per provider, but let me get you the actual data, specifics and the assumptions around how we put that together so you can see it. And we've had it, I think, for the last 3 or 4 years, so I'll also send you the link so you can kind of see some of the ones that have progressed. And it's not just behavioral health. It looks at all medical, lots of the medical area. It looks at some other service areas too, so you guys might find that helpful.
Thank you.
Great, thank you so much. Okay, so I'm trying to figure out where should I start first for my questions. So let's start with the basic one. So we've had conversations of obviously mental health screenings being a part of primary care. Do you think that, so as someone who works in primary care, I think obviously there's similarities between Medicaid and Medicare, but oftentimes, because of the reimbursements in Medicare, there's different incentives and so forth. And what I noticed is that in Medicare, there's always these incentives of going after like annual wellness visits. Like we have to do these AWVs in order to make sure that we're meeting the gaps, and we have to do them a certain time frame. Otherwise, us as providers are not being equipped with the right resources to tackle the needs of the patients. And so when you're talking about coupling behavioral health with primary care, is there a scenario where the state can probably do a rate enhancement for if you do as part of the annual wellness visit that a patient goes through, that you have, this is a standard level rate for the CPT code that you're billing for, but if you include a mental health screening, you can get a rate enhancement? Or maybe would it be, would we do it through the MCOs? Or I guess, like, what are your ideas that we can incentivize primary care to start including this as part of the standard of care? I think that's probably the better question.
Mr. Chair, committee members, Stacy Weeks for the record. So now you're singing my song. I love it. That's exactly right. I think that is how we incentivize providers to do it. I think mandates are harder and often don't work, but if we add the additional bump around behavioral health and incentivizing our primary care providers to be our frontline providers, I think that is really important. Now, when it comes to managed care piece, just remember, we do not negotiate the managed care rates, and this is often where states struggle when we're trying to do these types of different payment models. But if you were going to do something like that, you could put in the legislation that we would need to direct that type of payment, that the managed care plan would at least at a minimum have to provide a similar bump onto the fee schedule. So for example, if we say you at least pay the fee schedule, and let's say they pay a little more, they still would have to pass through that bump. So you could require them to do that. So you would just have to put that explicitly in the legislation, and we would implement it that way.
Yeah, and the reason that's kind of what I was trying to get at, which is a lot of the rates that are predetermined between the provider and the MCOs are negotiated, and it's proprietary based on the different MCO. It's the same way that we do it with insurance companies. And so my main thing would be if a provider was actually delivering on the request that the state government has entrusted the provider to do, which is we want more mental health screenings at the front line, right, as patients are coming in. What if we have them for 30 minutes? Let's ask those critical questions. But I want to make sure that the money actually flows, and that we can incentivize them to, if we're doing it right and we're meeting the requests of the state, then we can use those funds to bring in more mental health providers from out of state and so forth, and build our capacity. So I think that was more so just for my understanding. Second question is, I know historically with the federal government, we've talked about presumptive eligibility. I know that the Biden administration has made a priority of looking at presumptive eligibility of a means to improve access to care. And so from my understanding right now, presumptive eligibility is only based on hospitals here in Nevada. So is there an interest from your office, or I guess I'm just more looking for your feedback. What would be the feedback if we added more entities outside of hospitals to qualify for sites that could retain for presumptive eligibility? And can we add mental health as a subset as one of the key requirements, I guess? So, and the reason why I'm thinking that is, could that lead to more federal dollars that are coming in to get access to care for the folks that need it? I guess that would be my question on presumptive eligibility.
Mr. Chair, committee member Stacy Weeks for the record. I wouldn't see it as getting more money. It would actually, it does have a price tag, but it does help people get enrolled easier. I want to say, and I'm not over eligibility, so I'm not an expert on that area, and I don't have my colleagues in the room today, but I want to say that the state did expand beyond hospitals, but I would like to confirm and follow up with you. But there could be some low-hanging fruit and other opportunities. I know there's some federal law around who can actually do presumptive eligibility, so if you wouldn't mind, I'd like to take that back and follow up with you directly, and have DeWitt also part of that conversation.
Yeah, and the reason why I was asking that was I was actually looking at Cornell Law this morning before the meeting started, and I think that historically from the federal government, there is a track record of doing presumptive eligibility for mental health. They called it psychosis, but it's specifically for veterans of certain wars. And so I'm wondering, like, is this a conversation that other states have looked at as, let's not focus on having people go through this paperwork. If the care is there to be delivered, let's focus on that first, and then we can get paid later, right? I think that's kind of where my line of questioning was, so.
Mr. Chair, Committee Member Stacy Weeks for the record. I think that's a really good idea. Let me follow up with you on what we currently do, and then I will also ask. We have a National Association of Medicaid Directors, and we have a listserv we can send out a question, and I can see who all is doing this, and we can get some more information for you.
Okay, thank you. Next question. So I know that oftentimes when we talk about the services that get sent out of state, from my understanding, a good portion of them is in mental health. Last session, we talked about telehealth parity, right? Making sure that we continued some of the items that we did during the pandemic. And so I guess to me, my question is, are there actual mental health services that our state doesn't have the infrastructure for, and that's why folks are leaving out of state, or are folks leaving out of state because of a close proximity to another state? So the example would be like for Mesquite, right? If someone lives in Mesquite, is it just easier for them to go to Utah, or especially in parts of northern Nevada where they can go to Utah or Idaho? Is that why we're seeing people leave access to care, or is it because we just really don't have the infrastructure? And if so, what is the infrastructure that we need to focus on?
Mr. Chair, Committee Member Stacy Weeks for the record. I did pull some data before this hearing about out-of-state services, specifically for behavioral health in adults. There were only 43 members. So I don't think the problem is as big as it has maybe been told. I do think that for children, that's a different story, but I don't think it's also significantly large for children with behavioral health other than looking for residential placement. And the reason we're doing that is because we don't have the home and community-based services we need to serve children. And we're working on that. But I would like to follow up with our data analytics team and look at the actual services for those 43 people to see what they were, so you can have more data on that. But my guess is it is those border communities, or they're, now we do have telehealth, so maybe we're not seeing it as much because people are getting it through telehealth and it's covered and it's not considered out of state. But we are not sending a significant number of people out of state for behavioral health in the adult population.
Yeah, this kind of is, I think, the difficult aspect of this conversation of mental health throughout the day that we've talked about, which is there's obviously some level of need that we need to do, especially in the rurals, right, where there is no presence of a provider type, but then there's like that difficulty of like, is the volume there to even hire someone full time or to even stand up that facility? And so what I would like in our healthcare system, and this is just outside of healthcare, is I don't think that we should not be in a position where our providers are scared to go towards building a facility in North Las Vegas or East Las Vegas or parts of Reno simply because the reimbursement is not there. I think we should just try to figure out what makes sense, what doesn't make sense. Do we need facilities? Do we not do facilities? Can we have a model, right, that follows the patient? And that was kind of what I was asking with primary care. So I don't know if you have any discussion on that.
Mr. Chair, Committee Member Stacy Weeks for the record. I think the whole volume and need issue is a big one. It happens for OB as well in our rural areas. We heard that a lot from our hospitals when we did a rural hospital tour. One thing that I think we have an opportunity to do in this next managed care procurement is really encourage more of these mobile services as well as telehealth, and actually providing providers out there with the resources they need to provide those services telehealth. But I do think we have to think, some states are looking at a regional approach, so assessing needs by region and then figuring out what is that regional approach. Is it a provider who rotates, right, across the region, or is it part telehealth, part in time? I know that's challenging, and it depends on, the payers are all different, but I do know some states are looking more at that regional approach and treating it more like a hub and spoke model for behavioral health services, especially in the rural communities.
Yeah, I certainly agree, and I think that the regionalization is probably what needs to be done more from the state's perspective in terms of where our model needs to go. Because the needs are different whether if you're in an urban area or not, or if you're in Northern Nevada versus Southern Nevada. There are obviously themes that we all struggle from, but there's also unique items that perhaps are relevant based on what part of the state we live in. And then I heard you on, I know there's this conversation of medical fraud with billing that obviously exists. And so I want to make sure that your team has the support to go after those bad actors. I know that, I mean, I've seen it firsthand with home health care. There seems to be a lot of home health care companies, but not actually delivery of care. And so I want to make sure that if we are standing up healthcare businesses, that they're actually catering to the needs of the community, and that we're supplying the system as it needs to be. And my approach has always been, let's focus on upstream versus downstream. Let's focus on prevention versus, you know, obviously there needs to be a level of treatment, but we need to work together to ensure that the services are there and that we're treating it first versus letting it continue to the tertiary level of prevention or where it's a lost cause, right? I don't think that's where our state government should be in. But I think that's pretty much all my questions, unless if anyone else has any other ones. Vice Chair Owenlicker.
Thank you, Chair, and thank you for your presentation, Ms. Weeks. I just have a quick question. I think it's quick. You mentioned the importance of the hospital provider assessment and how useful that will be in making sure we have better funding for services. So I was just curious, I noticed that normally, you know, there are other categories of providers, and hopefully if we can expand to other doctors or therapists, but I also noticed that services of Medicaid managed care organizations are a class of potential provider. So what does that pick up? Because obviously their services include hospital and doctor services, but those are separate categories. So what is the category of services of managed care organizations?
Mr. Chair, committee member Stacy Weeks for the record. I think you're referring right to the federal law and the categories the federal law allows for provider taxes on. My understanding of that would be what we currently have, and we have it as a premium tax. So we currently tax our managed care plans. I'm trying to remember the percentage, but there is a small percentage, but it's all, you know, healthcare expenditures. And that part of that premium tax, called the premium tax revenue, we match with federal funding under that authority that you're referencing, and that goes straight to the general fund. So it is a driver of state general fund revenue for the state. So when managed care rates go up, the state general fund gets more money. I know that's not necessarily what we always want to see, right, from a like healthcare cost perspective, but it does drive more revenue for the state.
Okay, so thank you. So we're not using that for Medicaid reimbursement, it's just going for other, is that what you're saying?
Mr. Chair, committee member Stacy Weeks for the record. Yes, so when anything drops to the bottom line with the state general fund, it's used for however it's appropriated from that bucket. So it does not go back into Medicaid, unlike the private hospital tax, which was drafted in a way where the hospitals got their supplemental payments, and then what we took 15% for behavioral health needs from the revenue.
Yeah, I'm having LCB staff see how much funding that is, because that would be interesting to see what it leads to. I mean, there's obviously the caveat that Medicaid is one of the largest recipients for the general fund allocations, right? But it'd be interesting to see how much it actually turns out to be, and we can have conversations offline about it. But I think that concludes our round of questions. So I don't think there's anyone else that has any other ones, but we appreciate you, of course, for coming back. I know, of course, we have more work to do with our next meeting in June with Children's Behavioral Health. So we look forward to an update, and we always thank, of course, the team, your team, and all the work that you guys do.
Thank you, guys. Appreciate it. Thank you.
Thank you so much. All right, that concludes that presentation item. It is 12:22. We're going to go ahead and take a break for lunch, and we'll be back around 12:50, 12:45, 12:50. Recess is in session.